All right, we've made it to 8:01. I'm sure people will keep joining us. Thank you, Dave, for letting everyone in, but we might as well get started while we're all here. Welcome, everyone. I'm so glad you're all here. My name is Kayla Tabari House. I'm a clinical ethicist at the Providence Center for Healthcare Ethics, and I have the honor of welcoming you all to the 2024 Kinsman Bioethics Conference. I have the fortune of co-chairing the conference this year, and as we gather here today, albeit virtually, I'm truly overwhelmed by the sense of gratitude for each and every one of you for joining us on this cozy, rainy day here in Oregon. Please allow me to extend a special welcome to my wonderful co-chair, Dr. Tyler Tate, who will now introduce himself.
Good morning, everyone. Thank you for being here. We are incredibly excited for what we have in store today. It's going to be an action-packed day where I think we're going to all walk away having learned something pretty exciting. And I'm Tyler Tate. I'm a pediatric palliative care physician and assistant professor in the Department of Pediatrics here at Oregon Health and Science University in Portland, where I'm also one of the associate directors of the Center for Ethics in Healthcare, which I've been for the last, all of those things for most of the last 5 to 6 years. I will mention that starting June 30th of this year, I will be leaving OHSU, which both pains my heart because I love our institution, I love the state, and also is exciting. I'll be heading to Stanford University, where I'll be working in pediatric palliative care and bioethics as well. But I know that the relationships we have here will continue for many, many years, both in our amazing state and with the Kinsman Conference. I also just want to mention, as a co-chair, this conference would not have been possible without previous co-chairing, and I mean previous for this exact conference, from Dr. Susan Toll, the founder of the OHSU Center for Ethics in Healthcare. I took the baton over upon her retirement at the end of last year, and I'm grateful for all the work that she did prior to that time with Kayla. And I'll pass it back over to you.
Thank you, Tyler. I like to think once you're an Oregonian, you're always an Oregonian. So rest assured, within the Kinsman group, you're always welcome. And thank you, Susan, for all of your help as co-chair and for transitioning that to Tyler. It's just been such a pleasure to work with both of you. Like I mentioned, I'm Kayla Tabari House. I am a clinical ethicist, and in my past life was a nurse at the bedside. So this year, we chose to focus the conference on everyday ethics. And we did that to allow us the space to recognize a really profound impact that common ethical dilemmas have on the lives of patients, families, communities, and folks who work in healthcare. From the doctor's office to the dinner table, from the laboratory to the legislature, I mean, ethical questions arise all the time with increasing frequency and complexity as the days go by. And so by embracing the theme of everyday ethics, we really hope to underscore the significance of ethical reflection and decision-making in all kinds of scenarios that we encounter in our everyday experiences. Whether that's the allocation of limited healthcare resources, maybe it's the use of emerging technologies, maybe we're facing challenges navigating policy writing in the healthcare space. I mean, ethical considerations are really omnipresent, right? And they demand our thoughtful engagement. Throughout this conference, we're going to explore the intersection of medicine, ethics, and society. We're hoping not only to understand ethical landscape of contemporary healthcare, but also to equip ourselves with the tools necessary to navigate these challenges with both wisdom and integrity. We're looking forward to making the most of this virtual platform this year to exchange ideas, challenge perspectives, and we're really hoping to foster connections with people all across the state and the region that transcend physical boundaries.
And just to sort of riff on that before we launch into telling you about the schedule of the conference, I am really excited for this topic. I think for those of you who have heard me talk about ethics at all, I think there's such an often overlooked beauty sort of in the mundane that in clinical ethics especially, we oftentimes focus on sensationalistic cases and forget that the bulk of our lives, our ethical lives, is contained in these face-to-face encounters, and these just sort of basic questions about how we treat someone when we're tired or stressed. And there's few places that are as tiring or stressing as the global healthcare context. So I'm really looking forward to seeing how our various speakers help us learn to navigate the kind of everyday quandaries that we oftentimes find ourselves in. With that, I think we can proceed to let you all know what you have in store. But before we do that, I want to have another couple of acknowledgments. We have a special appreciation to John Kinsman for the endowment that he established, which provides partial support for this conference, and the Kinsman Foundation for their support in underwriting this conference, which has been going on for many years with their support, and it's such an incredible Oregon establishment. And also, of course, to mention with gratitude Providence Center for Healthcare Ethics and OHSU Center for Ethics in Healthcare, which this conference would not be possible without the support of these two institutions/centers.
We are so grateful for this year's planning committee members who we subjected to all sorts of meetings to try to make sure we could bring you the best program possible. So I need to take a quick moment to say thank you to Kevin Dirksen, Krissa Gaigon, Souza Headland, Prasanna Krishnasamy, Dave Hoyt, Lori Morrison, and of course, Tyler and I were there as well as Susan Toll. And then, of course, the wonderful Kinsman Conference volunteers. I cannot imagine what this would look like without the help of not only Dave, of course, Dave Hoyt at the helm, but also Anthony, Samantha, and Safa. We couldn't do it without you. Thank you so much. All right, we have made it to 8:15. Thank you all so much. Like Tyler and I said this morning, it's just such a gift to have you all here. And I'm so excited to introduce Dr. Denise Dudzinski. Dr. Dudzinski is a professor in bioethics and humanities and pediatrics in the Division of Bioethics and Palliative Care, as well as a fellow of the Hastings Center. She was chair of the Department of Bioethics and Humanities from 2014 to 2022. Dr. Dudzinski is adjunct professor in the School of Law and in the Department of Family Medicine at the University of Washington. She is chief of the University of Washington Medicine Ethics Consultation Service and director of organizational ethics at Seattle Children's Hospital. Dr. Dudzinski earned her PhD in ethics from Vanderbilt University and her master's of theological studies from Vanderbilt Divinity School. She is also certified in healthcare ethics consultation through the American Society for Bioethics and Humanities. And I'm sure there are a couple of things that I've missed because Dr. Dudzinski is really an example of someone who does it all and does it all so well. So thank you so much for being here today to talk to us about daily dilemmas in clinical ethics.
Thank you so very much. I just really am honored to be here and want to thank Kayla, Tyler, and Susan, and Dave, and everyone who has been a part of this. I'm really honored to be here. Thank you very, very much. Okay, here we go. Let me get this going here. Here are my objectives. I want to talk about the relationship between clinical and organizational ethics, especially as it plays out at the bedside. We're going to look at some case studies that include some common ethical dilemmas and see again how the clinical and organizational play off of each other and together. And generally, you'll see how they intersect throughout this presentation. I hope if I do my job well, that's what will happen. All right. So first, a lot of people have an understanding of what clinical ethics is. Clinical ethics is our how we address ethical issues, the many different ethical issues that arise in individual patient care. All clinicians are involved in clinical ethics every day. And then ethics consultants, clinical ethics consultants are involved in particularly complex cases that might need a little bit more help in somebody who might be trained more deeply in ethics. So I have done clinical ethics a lot of my life, and in recent years, I have turned more toward organizational ethics, which I also enjoy very, very much. And so the term here, many clinical ethicists do both, and many clinicians do both, right? Many of you are involved in policies that need to be put together for your specialty, et cetera. So, but what we're trying to do in organizational ethics is address the equitable, transparent, and wise resolution of ethical issues that arise between organizational values and healthcare delivery, such as duty to care, duty to provide high quality care, while also issues of distributive justice, how we allocate resources wisely and fairly, protecting the well-being of staff and demonstrating accountability to community stakeholders. Would it be okay if I ask everybody to just be sure that they're on mute? Thank you very much. Okay, let's see. The other thing I would say, especially about organizational ethics consultation, as I mentioned, we're always talking about how whatever it is we're talking about impacts populations, communities, not individuals. And this can be hard to do when your whole job is taking care of individuals. But we really are trying to think about what's the rule and the guidance for let's say, I don't know, patients who are requesting gender affirming care, for example, or whatever it may be. What should be our guidance there as an institution? And that's the general rule, in which there are exceptions, of course. There are always exceptions to a rule, but we're trying to figure out what the general approach should be. The other thing about institutional or organizational ethics consultation in general is that you have to have someone at the table who has institutional authority to change something. Otherwise, what happens is those of us without that authority all get together, we talk about what's not working, and we end up having nobody there who can change anything. That is not very helpful. So when we have organizational ethics consults, it has to come from someone who has institutional authority to revise something or build a policy. The title of that person doesn't matter. It could be a nurse manager, it could be a staff nurse, but the institution has given them authority over this, this job that they're going to do. This work often involves policy analysis and development. I write a lot of policies and help people write policies. I also write a lot of FAQs. So when something new is coming up and staff are like, there are a bunch of things that are hard for me to figure out what's exactly going on, we try to convene that multidisciplinary group of people and we start trying to answer everybody's questions. So now it's out there. People have a common way of talking about things. We're dispelling myths that often come up when something is new, etc. So that's sort of the way I do ethics consultation, organizational, and probably the way many, many others do as well. Okay, other things to keep in mind. Sally Bean has made this helpful comparison of clinical and organizational ethics. And you can see where the focus is in both. For example, in the second bullet over on organizational, you're avoiding disparities between behaviors encouraged and actions taken. You are trying to address the level of dilemmas associated with economic, political, and social aspects of healthcare. You are trying, I often find a lot of my work is trying to ensure that we have fair access for populations of people, right? That we aren't doing something inadvertently or not, or based on other goals that is inadvertently blocking some patients who need us from getting to us. Also, the other thing is that clinical ethics consultations and stuff are short, usually. Things may keep coming up, but they're short duration. Organizational is longer duration. So here is another very helpful sort of graph of some of the relationships between what's happening at the bedside and then what we do about that at the institutional level. And I want to draw your attention, if I might, to the last column, because that is what we're going to talk about today. we're going to talk about, well, part of it. We're going to talk about trauma-informed approach to violent patient behavior, okay? And this is a rough topic, a difficult topic, but something that more and more of our staff need help with. And for that reason, I'm going to show you how one of the ways we've tried to help. I'm sure there are many more on this call that we can learn from. So, disruptive, threatening behavior from patients. Of course, this can also come from other people, but I'm going to focus on patients just to keep us in one lane here, which can lead then to workplace violence. And I will say from the beginning, this could happen to absolutely anybody who is in close contact with a patient who's exhibiting these behaviors. But it goes without saying, the nurses confront this, the nurses' aides, they confront this more than anyone for the simple reason that their job is to be at the bedside all the time, whereas providers come and go. Okay, so here are some definitions of workplace violence. One from Occupational Safety and Health. And notice that this includes verbal attacks, although of course we treat the different ways that this violence occurs in different ways depending on what's happening with the patient. And so it can include overt acts of violence, threats, verbal abuse, harassment, and other conduct that generates a reasonable concern for safety in the workplace. Also, threatening behavior, such as shaking fists, intentionally slamming doors, punching walls, throwing things, vandalism, etc. All of which can be scary for those who are caring for them. I have noticed, and here's one set of data, I could have drawn it from a lot of different places. I think we've all noticed that since the pandemic, there's a little more of this or a lot more of this, depending on where you're working. And it requires the organization to help address this and keep their employees safe while also executing our duty of care. And we'll talk about that in a moment. But here's a little bit of data. 8 in 10 nurses have experienced at least one type of workplace violence within the past year. Half reported an increase on their unit in the previous year, and few report a decrease. There's multiple types of workplace violence that people are confronting or navigating on a daily basis, including verbal threats. And you can see some of the disturbing data about what nurses are experiencing, especially in the last year. So here's some of the data also. I'm just going to pause and let you take a look at this. This relates to over the past year, what's changed. And I will just say that this issue of being verbally threatened, that is very, very high. All these numbers are very, very high, but this is incredibly high. And it goes without saying, this takes a toll on people's sense of safety in the workplace, in people's sense of, well, in a lot of ways. I'll just leave it there. There's a little more data regarding how employers try to address workplace safety for nurses. And thankfully, there is some training in a lot of places on workplace violence. This is an important component, and it would be utterly insufficient if it were the only component to try to protect our staff. All right, I'm going to give you a case. Okay, so Marcy's 47. She has cerebral palsy and a history of spastic quadriplegia. She has bilateral lower extremity contractures, and she's admitted for chronic pain soon after the sister that she had been living with died suddenly. She has no children, Her brother is her main family member. He calls frequently, but he rarely visits. He lives in another state. Her hip, back, and lower extremity pain are resistant to treatment, and she reports 9 out of 10 pain most of the time. She often makes racist remarks to Hispanic and Black staff, and she will yell these remarks and hurtful, hateful comments to passersby. I am making a deliberate choice not to get more specific. For the sake, I think everyone can imagine what these comments are, and I will not be more specific about it, just so we're clear. She persists despite limit and expectation setting from the nurse manager and from the attending physician. She'll also grab at hair, she'll spit, she'll scratch during cares, and she'll call for assistance a lot with non-health related needs. Now, her disability means that it's appropriate for her to need more help, obviously, and nurses are happy to do that, but it's getting a little bit, a lot, right? A lot. She's requiring a lot of non-health related requests and calling the nurses in there a lot of the time. So, of course, this nursing staffing is rotating, and more nurses are requesting not to be assigned to her and or mostly to get quite a break in between to help them out. SNF and adult family home placements have been challenging due to pain management and these inpatient behaviors, and she's been hospitalized for 4 months, okay? So keep this in mind. I just want to point out before we dig more deeply, when I am focusing on the organizational ethics issues that a case like Marcy brings up, throughout my interaction with everyone, I am doing the things in that top box. I'm constantly gathering more facts, understanding the stories and perspectives of all the various people who are involved. I'm asking for a lot of clarification and advice. How have we handled this before, etc. And then I do a bunch of offline research. This is happening throughout. But in general, you're trying to get a group of stakeholders together to try to figure out what else the institution needs to do to address these issues, right? So you're going to look at relevant policies, guidelines, and laws. You're going to think about distributive justice and equity, and you're going to end up hopefully with policies, guidelines, something that the staff can come to for help, so they don't have to start all over every single time, and they can easily find the help they need from the work, from their managers and from the workplace. The first thing we want to ask is, what type of situation is this? All of them are bad, but we also want to be clear about our interventions to protect staff may be different depending on what's occurring, okay? And in Marcy's case, we've had basically all three, and especially the first and the last. And the first thing I do before we start talking about this is what my colleague has called an equity pause, which I think is helpful. So in addition to asking what kind of situation is this, it is extremely important that we all differentiate perceptions of threats and violence from patient actions of threats and violence. It is a part of the widespread discrimination that many people in our society experience is because there are undue associations between some people and the possibility of violence, right? People of color often experience this, male people of color in particular. These are unfounded and unethical, and we're all working on trying to do way less of it. It's mean, right? It ends up being mean. So people might feel fear in a situation, and what the response might be to really examine why they're feeling fear in a situation, especially if there are no behaviors, threatening behaviors or violence itself, okay? So as an ethicist, I'm paying a lot of attention to this distinction. The anticipatory fear of a behavior leads to equity issues that we want to try to tackle on the front end, not on the back end. And this is, I want to say, is done not in a way of sort of cancel culture. It is done in the way of, we've all started somewhere to try to get better at being anti-racist, anti-sexist, etc. So wherever that person is starting, how can I, with kindness and support, help move them to further along down the path of equity? In addition, at the same time, which makes this difficult, when a patient has had a history of these threats and violence, it'll be in the chart. It'll also be remembered by people who have been staffing and helping that patient. And it will be, people will be on alert. This is to be expected, and also can lead, kind of feed into this equity issue. So we all have to help each other. I always say in healthcare, what I love about it, why I love working here, is we are a moral community, right? So we just have to help each other and hold each other in this, and help each other get better. So many of our policies will say, if you feel your safety is in jeopardy, exit the space immediately and call for assistance. This is in general a very good policy. And at the same time, we also want to think about where and why we feel unsafe. This is not a concern for Marcy's case. We know why we feel unsafe and have really good reason to step out of the room. And you're also trying to assess the magnitude of the threat. As soon as it starts to happen, I feel like nurses in general are very kind and accommodating to patients from who are displaying lots of different behaviors. Sometimes they'll wait a little bit to get help. In general, I'm thinking get help earlier, and then we can help protect you better as time goes on in general. That may not have been true a few years ago, but I think it's probably the best strategy now. So here, if we think about the clinical skills and the clinical ethical orientation, first of all, we have a duty of care. This duty, all healthcare providers, all healthcare workers who are directly providing care for patients in any way have a duty of care. This, I can't emphasize enough how important this is. This is basically a social contract that says, I have special skills and knowledge that the majority of the rest of the society does not have. If people come to me, I must use my skills and knowledge to help them, pretty much in every case, right? If I don't, think about the implications. If we get to say, I'll take care of this patient, but not this patient, if in general that were the rule, of course there are exceptions, as I said before, but if that were the rule, a lot of people would be sick and ill and injured without help. So this duty of care is extremely strong. And it means that we are trying as hard as we can to help Marcy and to keep providing care for Marcy, as we are also trying to protect our staff. We also have always, we want to protect and respect the vulnerability of patients. And we can also see in Marcy and the nurses, whenever I do moral distress debriefs, they're very on board with the vulnerability of patients, even patients who are mean to them. And so one thing from a clinical standpoint, when you're thinking of the nurse standing at the bedside, well, we're going to build some skills. What can we help? What can we teach people about leaving the room, about setting firm boundaries, about verbal de-escalation, that all of our staff can have in their back pocket? They may still need help, but at least they're not out there at sea without some skills in their back pocket. Organizationally, we have to protect staff, right? And not only from physical attacks, but from discrimination and harm. And so this is going to be where we're going to say, okay, institution, what are you going to do? How are you going to help? What resources do you have to marshal in these cases? Okay, both are extremely important, but I would never rely solely on everything in the left-hand column. It is utterly disrespectful to staff who are in harm's way. So we have to do a lot on the right-hand side. Okay, So we think about there are lots of different ways to think about this, and we will be using those strategies through the course of our time together. But one way is to think about what rights do patients have. One is the flip side of that duty of care. I can generally expect that I will get help from you when I need the kind of help you know how to provide, and few other people do comparatively in the society. You are a scarce resource in our society, and it's important to think about that. And I think we had a reminder during the pandemic, but it's been true. It's always true, actually. We have that social contract that I mentioned. We also, patient rights don't mean we have the right, if I were a patient, to come in and say, here's what I want, doctors and nurses, and I don't want this, and I want this, and I don't want this. What we really have is the right to say yes or no to beneficial, non-maleficent care that is offered by the provider who is caring for us, right? This respect for autonomy doesn't mean I get to do whatever I want. I have to keep saying this over and over again. Respect for autonomy never means everybody gets to do whatever they want. It always has boundaries. And in addition, as a patient, I am not permitted to discriminate against staff. And I also will receive care based on need, not based on social worth criteria. So for example, if a prisoner comes into our hospital and let's say they've been on a shooting spree and we are also treating all of their victims, we treat that prisoner who has been shot as well, right? We don't start to go, oh, I like you, I don't like you, I'm treating you, I don't treat you. I know this is obvious, but I'm going over it. And then the ANA has noted rights, some of the rights of nurses. There are many more, but I'm highlighting these. So first, work and practice in environments that ensure respect, inclusivity, diversity, and equity with leaders who are committed to dismantling systemic racism and addressing racist behavior and sexist and many other behaviors, discriminatory behaviors that negatively impact nurses. Yes. Period, the end. So now we got to figure out how to do it well. Safe work environments that prioritize and protect nurses' well-being and provide support, resources, and tools to stay psychologically and physically whole. And then also the freedom for nurses to advocate for their patients and to raise legitimate concerns about their own personal safety without fear of retribution, retaliation, intimidation, etc. Again, yes, period. The institution has to make sure, leadership down, that nurses feel like they can say, I need help, something's going on here that I need to bring to the attention of nurse managers, etc. So the institution has a very high obligation to do all three. But step one here, if we're talking about Marcy, is, as I said, when the speech is happening, let your manager know, and we're going to start working on this now, as soon as we know what's happening, right? You're going to chart it respectfully, but you're going to chart the behaviors. You're not going to talk about judgment calls about the patient. You're just going to chart, this happened, this happened, this happened, this happened. I left the room after this happened, etc. The other thing that's really hard about this, of course, we can't stop patients from all behaviors that are problematic. And particularly in safety net hospitals like where I work, we also are going to say, try to treat those people. And a lot of people don't, there are mental illnesses, there are previous traumas, all of these things come up when we try to take care of them that can factor into behaviors that we see that can be dangerous. So we can't say, oh, we're only going to take these kind of patients. We also can't say completely stop all the patient behaviors often, but we can help staff who confront it and hopefully persuade the patient to stop too, but we can't rely on that, right? So the other thing that we're going to do that is we're going to check for policies and procedures So to see what kind of help we have. Now, in general, bedside staff, clinicians in general, often don't do this right away. And so people like me come and say, hey, actually, we have some resources. But this is a place where managers, where attending physicians, just being aware that we have these available can make things easier, especially in the beginning. And the other reason that these policies are important is if we have a standard way of addressing this, we're more likely to be fair and we're more likely to be equitable, instead of going, I'm treating this situation like this and this other situation completely differently, but depending on who's in the situation and what's happening. So a couple of highlights of our disruptive patient or visitor policy. Verbal de-escalation is one of the things, an evidence-based approach used to reduce the intensity of a conflict or potentially violent situation. But of course, in the situation, even if you've had a little training about it, you're going to need more tools again. You're going to want to review things to figure out how do I do this. This can include calm communication, self-regulation, active listening. And often there may be one or two people who tend to have a little bit smoother relationship with a disruptive patient. And I always want to find out, is there something they're doing or not doing that the rest of us can learn from also, right? That might make it easier for everybody. So, and that's more patient specific, and this is more general, the verbal de-escalation. There are all these resources linked. When I go to look it up, there are all these resources linked to the policy. And so if I'm trying to help staff, I can go to all of these things and bring it to the staff's attention. And we can work together to figure out which of these we might need in a given situation and which other staff support we might need in a given situation. Okay, so now I'm going to open it up for a second. I'm just going to do this way so I can see some of the comments. I'm going to ask you in the chat, what can staff do in the situation of Marcy? Let me put Marcy's case up for just a second so you can refresh your memory. Okay. Now I'm going to ask, okay, in the chat, Kayla and Tyler, I will ask for your help kind of curating this. Can you tell me what you think staff could do to reduce the risk of getting any of these bad behaviors when they're caring for Marcy? And please consider staff safety, patient safety, duty of care, and equity and fairness. See if I do this.
So far I'm seeing in the chat some great questions, which we'll definitely get to later. I'm also seeing comments like, maybe let's start with looking for better ways to manage her pain. Someone else says staff can advocate for improved symptom management. The next comment says pain management improvement.
Great. So here's an example of why I love working in healthcare. This happens every time I work with nurses and doctors, but I do a lot of this support with nurses. They always focus first and foremost on what the patient needs. Thank God, that's why they're good at their job, and that's why we're so happy to have nurses around. So that is absolutely true. What I will tell you in this case, we have tried tons and tons of different things, and we're sort of a little bit stuck right now at this moment she really experiences a lot of pain, even with boluses, even with trying different ways to manage that pain. She sort of is stuck there despite our greatest attempts.
Other responses include don't threaten the patient verbally in response, assign caregivers who maybe don't fit the racial profile that she tends to say negative things towards, ask the patient what her goals are. Other comments say behavior is communication. What is she communicating? Someone says, start every encounter by saying, I'm here to help you. Another comment, setting clear and kind expectations around respect for both patient and staff to create safety. Someone says, center her voice in her care. Another person says, telegraph everything you do and give her choice whenever possible. We've got request a palliative care consultation, seek a patient advocate to have her work through. Perhaps this is not only physical pain. And the last couple comments I'll read, set limits on behavior that will be tolerated during care. Nurse could leave the room and try again later. And also, is it total pain? Are there other providers, social work, chaplain support that could be helpful, maybe attending to her grief given having lost her sister?
Excellent. Thank you, everyone. Exactly, right? All I can say is exactly. So we're going to try to do all of those things. And notice that a bunch of staff are there to help you. I'm there as an ethicist, chaplains are there, nurse managers are there, security is there, stat team is there sometimes. There's all these people there to help you. And I think sometimes people get a little shy about asking for help, and I just want to encourage you not to be shy. Okay, very good. Thanks so much for that. Now let me just try to get back to, there we go. 1 second here. Okay. Now I'm going to ask you, what can the organization do to help staff? So this includes strategies to improve patient behaviors, to set boundaries, and to navigate patient behaviors. I'm going to say one thing before I say this. We don't talk about patient contracts anymore. We mostly talk about care plans. Right? Because in fact, we can talk to the patient and will talk to the patient about not doing these behaviors, but there's no actual contract there, right? We can't punish the patient if she doesn't do the behaviors. We're not going to, unless things get really, really out of control. We're not kicking her out, right? So really what this is strategies to help the staff cope with behaviors while we also implore her to stop them. So we won't talk about contracts, but you can talk about care plans. So what do you think? Let's see. What do you want from the organization in these cases, in these situations?
The first comment is support lower RN to patient ratio for the assigned nurse to the patient so they can carefully manage interactions. Yeah, other folks are saying perhaps consider a smaller patient load. Now we've got more comments coming in. Good training and staff support. Maybe encouraging the nurse manager to lead debriefing at the end of shifts. Encouraging the use of narrative medicine to help caregivers deal with stress. We could rotate staff to avoid burnout. Another comment says clear messaging about behavior expectations across the setting. Another person says, what about a nurse partner to share patient care? And then the last one I'll read for now, a member of leadership to visit the patient and round with staff.
Great. And all of those things should happen. Sometimes to a sitter, so loneliness might be a factor. Somebody sitting with them. And then the tricky part is, yeah, so there's a lot of tricky parts in this. I won't even get into the specifics yet, but thank you very much for that. That's exactly right. So let me tell you some of the things. So one thing is some of the actions we can take is trauma-informed engagement. I'm going to show you one of the kind of tools, just-in-time tools we have for our staff. Apparently, workplace violence de-escalation training now happens within 90 days of hire. I'm sorry this is even necessary, but it is. And then the other thing is resetting boundaries. So this is a situation where her behavior is negatively impacting and hurting other people. And I often find that, and it's hard to keep setting behaviors when you're the one always at the bedside. I get that, and you're going to need help, and we're going to provide it. But at the same time, the consistency of all the nurses caring for her, being consistent about the boundaries will actually help. Inconsistency will help less because she knows that sometimes she can just, kind of let everything out and be mean, and other times she has to be more careful, right? So this is like, we say things like, it's okay to be upset. It's not okay to call me A, B, and C. I'm leaving the room anytime you call me A, B, and C, or do X, Y, or Z. And of course, there may be instances in which you need to stay because of something imminently unsafe that's happening to her. I get that. Then you can bring somebody else in if at all possible, but mostly many things can wait, right? Unless it's an emergency, things can wait. And getting in the habit is so different than how we usually do things. People feel like they're being mean. And I'm often standing there as the ethicist going, you're not being mean. You have to be kind when you say it and how you say it. You are not being mean by setting boundaries to keep yourself safe and to not tolerate racist comments. You're not being mean. We might do a behavioral care plan, like I said, and then all of us kind of do the boundaries and help each other because it's hard, and so that we don't get this splitting. Okay, so here is one of the guidance documents that we have, okay? And it's helping our staff and myself, because I'm not a behavioral health person, kind of understand the difference between anxiety behavior, defensive behavior, and then risk behavior, as well as what we can do to protect both staff as well as the patient in these circumstances. And so you can see the other thing that I'm going to talk about in a second briefly, but this gray triangle is, of course, if you go in to provide any kind of care for this patient and she might pull your hair or hit you or spit on you or something, we also have to alert other people so they don't get hurt. And the way we do that is simply, the gray triangle simply says, check in with the nurse before heading into the patient's room. It doesn't say, this patient is mean. It just says, always check in with the nurse before heading into the patient's room. Let's see. Here is more detailed guidance, right? Active listening and observe. Speak in a calm, respectful manner. And I often, when I'm trying to help folks, I'm like, we can practice this, right? And sometimes there will be instances where somebody can't do this in that moment. Some staff can't do it in that moment. It was too upsetting in the moments prior. We can respect that and help that staff person and get them out of that situation. Often, not always, but often. We can try our best, right? Also, like things like I wouldn't have necessarily known, respecting personal space. Don't get too close. Even if, when these things are happening, even if, you maybe want to touch them out of kindness, maybe you don't want to do that in this circumstance, right? The clear directives that happen, as you see in the middle column. In this column, physical interventions may escalate the patient, and it may escalate anyone, frankly. So you're trying to figure out how to step through this without like bringing all of security, if at all possible, because it's likely just to actually make things a little bit worse. And then you can see what happens when we're talking about injurious behaviors and all of the things that we're going to do to try to help our staff under these circumstances. Okay, so this is both coaching the staff. Here's what you do right now when your brain's all flooded, because it doesn't matter that you had your 90-minute training a year ago, you're flooded. You need help right then. Again, we're going to do an equity pause. We're going to take a look at racism, sexism. It's confronted everywhere all the time. And this means, as I just mentioned, that some staff who are affected by this may not have the energy to once again fight it off, right? To once again address it. I think we can be respectful of that and help that staff, right? In those moments. It still means they're going to come back and take care of the patient most likely when they have had a break. But, we can help. Like, I'm not experiencing racism every day. I have some more energy maybe than the person who has had it over and over and over and over again the past 3 days. Ask what they need and offer it if you can. And then, of course, rotate staff assignments. Okay, so here's this gray triangle right? And so it's giving, staff sort of know what that means. And then it's also giving people a sense of you're having a behavioral care plan. So we can all look to that. That's also in the patient's chart in very respectful language, but also trying to figure out how to navigate what we're seeing with her. And then we have kind of a checklist. So for serious threats and acts of violence to staff, there's an action plan checklist. And so that means, and I think this, you see that the first thing is upon notification from a clinical area, the nurse manager is involved. So now the nurse manager, as soon as possible, is taking on a lot of these actions to help the nurses. We are, depending on what's happening, ensuring that we have public safety available, but also maybe not rushing into the room. So we're going to try to work with them who know how to handle those situations with what we know about how to be respectful, but also be firm with our patients in these scenarios. So what we also recently did, which I think is working out pretty well, is, a code gray, if you call a code gray, everybody comes running, including security, and it can escalate things, as I mentioned before. So there is now a behavioral event response team. We call them BERT, and this is people with training in behavioral health who will come first, provided violence isn't happening in that moment, but some in the earlier, with verbal abuse and other kinds of things, they may be coming to try to both talk to the patient and talk to the staff and try to figure out strategies that might be helpful to reduce the behaviors from the patient as well as protect staff. And this has been really great. And so we'll see, hopefully we can continue to have something like that. And so they've started responding on a few units in general, and now I think they may be available throughout the hospital, which we're really grateful for. I think I already sort of went through this, apologies. Okay, let me pause for just a moment and ask if there are any other comments about this case ethically that maybe I missed that you think are important to highlight here.
Yeah, I'm happy to flag one. Someone early in your wonderful presentation said, had a question about charting behaviors. So the question was like, should charting behaviors include very explicit call outs, like directly quoting what the inappropriate language was? Or should we just provide an interpretation of that language? For example, quote, used racist language. And then we got a second comment to that question from Dr. Coleman. It says, to that question, quoting racist comments in the chart, actual quotes avoid ambiguity, especially in the era of patients reading their own notes. And he says, as a Black physician, I personally prefer to read about patients' use of, quote, the N-word to get a clear sense of the emotional risk to myself. Not everyone feels this way, however, and it's a real dilemma about how to not traumatize other chart readers who are trying to do their jobs, but also wanting to be clear about what's happening.
Thank you very much for that comment. It's very helpful. Probably there are multiple ways to handle this, as we're seeing. But one thing that comes to mind for me, and maybe it depends on how often it's happening with a patient, like you don't want to read this every day, right? But I think the facts are really helpful, right? The N-word, not the actual word, right? Or other kinds of really terrible things that the patient said at first, because it's not like, then it takes that like interpretation level out, but it may be after you've done that for 3 days and it's now the end of the month, you maybe then strategies might change. I think actually all of you clinicians might know better about how to handle that. So I appreciate any advice that you might want to offer each other in the chat. Anything else? Any other?
Yeah, the other question that we got was sometimes patients' behaviors are involuntary due to mental illness, cognitive impairment, or neurological injury, et cetera. maybe not for this case in particular, but in general, how do we balance the obligation to care for patients while ensuring for staff when that's the case?
Great. Which perfect question leads me right into the next case. Okay. So now I've got another case, which is basically I made almost identical to the first case, except we have a 28-year-old man with a TBI from a motor vehicle accident 8 years ago. And otherwise, he has some spasticity, but he's strong. He's 28. He's stronger than Marcy. And otherwise, same thing, but his mood can change without warning, but you all know it's from the TBI, okay? So unlike Marcy, who had full decision-making capacity, Malcolm has diminished decision-making capacity. And many of these behaviors don't appear to be voluntary. So everything else basically is the same. And so now I want to ask you, I'm going to pause. I want to ask, do you treat this situation differently? And how? How would you respond differently than the way we did with Marcy? What would you do differently? So let me open that up to the chat. Were we getting any responses, or should I just keep moving on?
I was going to give people a couple more moments, but we have a few coming in. Let's see.
Okay.
I would advocate for managing the agitation as a symptom. Must keep your distance to avoid physical threat of injury. Next comment, same stress on caregivers and staff. Next comment, yes, this is a dysfunction and not volitional, hence the main intervention would be staff training on TBI and support. Next comment, yes, this needs to be treated differently. The threat of physical harm is higher. And then his medical diagnosis can be easily seen as a contributing factor here.
Great. Okay, so this is where I want to get at something. Basically, why does the patient's decision-making capacity, if we're worried about staff safety, the unsafe behaviors are happening exactly in the same way in this patient? Why do we feel differently about it as staff caring for him? Can we pause and see if people want to answer that really quickly?
It sounds like from past comments, there's a focus on whether and to what extent it's volitional. Someone says maybe less about decision-making capacity in particular, but more about a brain impairment. Someone says patient maybe doesn't have a choice. Next comment is loss of decisional capacity. Someone says voluntary versus involuntary.
Yes. Okay, but so here I'm going to get a little bit technical, and I'm going to say this. Let's see if what I have on my next slide. Okay. Here's what I want to point out. The impact is the same, potentially the same in both patients, especially the physical. If he kicks and she kicks, everybody's kicking me, right? And it hurts. He may be even stronger, right? And the kick may hurt me more because he's stronger, right? That's for no other reason. Now, if we only are focusing on impact, I don't get calls to help. We don't get as many calls to help in these situations for Malcolm as we do for Marcy. And the reason but why? Because the impact, if I use something called a utilitarian or consequentialist framework, you're just you're in harm's way just as much. And whether it's Malcolm or it's Marcy, right? Now, one way that may be different is that some of the verbal abuse and discrimination, people are still impacted by it, even if it wasn't volitional. But at the same time, people might be less impacted or more quicker to forgive because they understand he might not know what he means. So the verbal part, you can see the difference. But so this is interesting, right? Because it means that we still have to protect staff, don't get me wrong, but it means that there's more tolerance in that Malcolm area because it's not volitional. And that means that there's moral culpability. If there's moral culpability on the patient, it seems we treat the situations differently. And I think we need to pay a lot of attention to that as well, because in all cases, we're going to try to protect staff. And why is it more okay sometimes for some people in one circumstance than another if the harm is the same? Okay, I'm going to leave it there because it's a hard question, but it's ethically salient. And it also speaks a lot, again, to the goodness, the inherent kindness of people who care for patients, right? To recognize this difference and to say, we're going to have a wider berth of tolerability for patients who don't have decisional capacity, even though they may be strong and it may hurt. Okay, great. Thank you, everybody. All right. Quickly, I have, well, actually, I have one more example, but I think what we'll do now is just stop because I think I have, well, no, actually, I have till 9:30. Is that correct?
That is correct, yeah.
Okay. So let me do really quick one other example. I'm going to go through this other example a little bit quicker. This is our medically futile, medically inappropriate treatment, which I took the lead in drafting, but with very close contact with palliative care and critical care and a bunch of other people. But sometimes I like drafting policies, and it takes it, my clinician colleagues are very, very busy, and it allows things to keep moving forward. And I'm happy to do that. I enjoy it. It's part of my job. Okay. Let's take a look at this case. We have Mrs. F. We have an 80-year-old woman with non-resectable lung cancer, diabetes, hypertension, chronic renal insufficiency, severe degenerative joint disease. She lived in a nursing home, was stable, walking short distances with a walker until she became markedly short of breath. She's admitted, diagnosed with lobar pneumonia, has 3 kids, 8 grandkids, no living will, and says repeatedly, "My fate is in God's hands." So she starts to improve, but then she develops high fever, septicemia. Now she's on dialysis 3 times a week. Antibiotics, vasopressors, and fluids are not preventing hypoxemia. And she's now developed acute renal failure, and she's become obtunded despite maximal treatment. So dialysis in the vent will be needed. Well, they've started, but they're thinking now more chronic dialysis will be needed to prevent imminent death. And physicians recommend comfort care. The family, in keeping with what Mrs. F has said, wants everything done, including CPR. Okay, so this case is familiar to everyone, right? I'm now going to talk about, there are lots of skilled practitioners who can help us through this, and we're going to ask a bunch of them to help us. But in addition, how could organizational ethics help in this case? So futility basically means leaky, untrustworthy. So no matter what you do, you're putting things in a bucket. The bucket's supposed to be sound so I can carry the water from one place to another, but it's not working, right? And so now my bucket lacks integrity, and I don't know what to do because I'm doing all the treatments and it's not having the impact. It's not reaching the goal that I'm trying to reach, right? I'm going to skip that. Okay, so some people don't like the term medically futile. I'm not going to go down that path in this period of time. Nonetheless, I like the term. It was coined among clinicians from my department. And I think it's still relevant, although I will say you should never, ever use the term in front of patients and families, but the concept is relevant for those of us who are trying to figure out what to do, not talking directly with the patient and family. So something's medically futile when a medical judgment is made that the treatment would have a very low probability of producing the desired benefit. And of course, we might disagree with what the benefit is. I get that. That's a part of it, but that's not unique. I mean, that's always going to be true. This comes up. always the determination of medical futility according to our policy is corroborated by another provider, another physician. This is just so that we're not going down a path that's a little bit idiosyncratic, right? So that, you know, another physician is kind of corroborating that this makes sense. And for us, and in our policy, consensus among healthcare providers is important. So one thing we put in our policy was a couple of things. First of all, a goals of care conversation needs to happen soon after you're starting to recognize this. If it had not already happened, call palliative care if you need help, okay? And really, one of the big things is call palliative care if you need help. Please, fast, please get help. But then you are also trying to say, let's distinguish between consensus among those who know the patient well, including nursing, versus a couple of people think we've reached the threshold of medical futility, but not everyone. In our opinion, and in the policy, we say you really need pretty broad consensus among the healthcare providers before we even bring this up or talk about anything, any withdrawal. Otherwise, it becomes a mess. And it's not really fair to patients and families, because if you guys don't agree, something else needs to happen. I mean, we're not at the edge of medical futility then at that point, okay? Okay, I'm not going to get into these concerns. One, I do want to mention there are important justice concerns that arise when we talk about medical futility. Medical futility appeals or medically inappropriate treatment appeals, whichever you prefer, should not be made because one doesn't think the patient deserves the resource or that someone else deserves the resource more. Medical futility and justice need to be treated completely separately, because you saw the definition of medical futility. It's unlikely to meet the clinical goal, right? That's different from making judgments about who deserves something. And really, we kind of steer clear about who deserves things, and we mostly provide care based on who can benefit from it, right? That's how we do things. So inexpensive treatments may still be futile, right? So this isn't about allocation of resources at first in the evaluation of medical futility. So it's not uncommon we also sometimes continue medically futile treatments for a period of time when we believe we shouldn't, right? So another thing, the equity pause here, is examining why you feel so strongly this time that we absolutely shouldn't continue, when really, when you look back, you had 3 patients in the past month where you kept them on the vent, even though they were coming to terms with things and you thought this isn't helping anymore, right? So we have set a very high bar in the policy for unilateral withholding or withdrawal. I think CPR is a little different than something like the ventilator. I won't get into that. I think that's a little different, but it's a form of withholding. But we do permit unilateral withholding or withdrawal of life-sustaining treatments when there is broad consensus that continuing to do so is not only not beneficial, but often really maybe have a tinge of harm in it. And we've tried everything else. So multiple conversations with a family member is likely the time that they have with their loved one to see what's happening, as well as respectful and not pushy conversations with family. Often families will come around. That's better than a unilateral withdrawal, which will make them mad, rightly so. You know, we shouldn't be doing this a lot. So our policy walks through how to do all that. Have these kinds of conversations, get help from palliative care. Also, ethics can help you, but if you get to the end, you also have to, this is the potentially inappropriate treatment, which is basically a term that's used often interchangeably, but may be used as an alternative to all forms of medical futility except physiologic futility. But the point is, if I go, if I go back here, once we get to the point where we're thinking about unilateral withholding and withdrawal, the policy says basically palliative care by that time has to be involved. Ethics, it's recommended to be involved, and the medical director needs to be aware, because we rarely do this. So this is now an institutional. First of all, the team would need the backing of the institution. Second of all, the medical director is going to be on point for some of this because now the organization holds responsibility as well as the team. And just to shift briefly here, many of you are well aware since 2015 that this alternative of potentially inappropriate treatment has been recommended by a constellation of clinical oversight groups. And so this is, you can see the definition. And let me just ask now, and I would say in general, physiologic futility, as opposed to, for those who want to differentiate, as opposed to medically inappropriate treatment, physiologic futility means it will not work. It's comparable to saying, I'm going to give antibiotics for a viral infection. You're looking at it as a clinician, you're just like, these things don't match up, it's not going to work. But in general, I find people don't have a lot of ethical problems with saying to someone, we're not doing that, when it literally will not work. It's actually the ones where we are making judgment calls, as clinicians must do as part of their job, about whether something's beneficial. And that may be in opposition or in contrast to what the family thinks is beneficial. And that's where this strategy of gentle support that palliative care helps us with is what we're going to do first. And then if we're up against the wall, we might consider unilateral withdrawal. Okay, so here's our case. And so I'm going to pause again and ask you, should CPR, the vent, and or dialysis be, let's pretend we're at the stage where we're at a withholding stage, right? Well, no, I'm sorry. Let's just look at the second question since it's already been started in the prompt. So should they be discontinued, the vent and dialysis? What do you think? Offer to discontinue, seeing that. I'll just grab a few here because then we'll turn to open questions. Yes, so I'll just point out that our policy and general often practice would be to have these gentle conversations, and we provide some guidance even in the policy, which palliative care would also offer this advice. But you're not, during this period of time, you might be doing time trials. That's in the policy. You might also be, you're kind of coaching the team not to keep going, well, you're just unrealistic and you'll come around, but to really be like, okay, let's get in this experience with them. If I also was worried that this wasn't the right thing to do, what questions would I want answered? So you're not pushing during this time. You're really just providing whatever support the family needs. Anyway, so what has happened, what I'm going to say about this policy, I'm going to stop sharing now. What I'm going to say about this policy is that our medical director, every time he sees me, he goes, thank God for that policy, because every time, and I feel so happy about it, because every time he says, we just step through the policy when this comes up, every single time. We do the same thing, and then we go from there. And so I feel happy about that because we were able to help people, and it was all a very multidisciplinary enterprise. Okay, so now we have time for questions. Thank you for your attention. I hope it wasn't a waste of your time.
So we have quite a few comments unpacking a couple of these different cases. I think certainly for a case as potentially impactful to a patient's life and the family's life as this last one, I think we could have spent a whole hour talking about the details of the case and next steps, but I appreciate you highlighting, I think just at a high level, that there are policies that can help us navigate some of these type of tough questions. I did want to call out first a question earlier in the chat that I don't want to get missed.
Okay.
Someone says, how do we work to turn down the volume on groupthink on units, not to label and stigmatize patients where they're maybe labeled with a reputation already on the unit that's not fair, equitable, or trauma informed.
Yeah, of course, that's hard. But a couple of things that come to mind is leading by example. So anybody who's in a leadership position demonstrates this sort of calm response. And I think all of us who work in healthcare must always use respectful language, even when you're behind closed doors and you are mad about what's happening. You are allowed to share how mad or sad or upset you are about what's happening, but never insult the patient. Never. So you're hoping that all of those things are happening. All of those things kind of turn things down. And then what we do is we give people an opportunity, if we can, to share their frustration with us, so that it's not just them, it's a collective experience. So let's have a collective opportunity to both exhale this pain together a little bit, and then also come up with some strategies that we might not have thought of if it was just two of us.
Wonderful, thank you. I'm seeing in regards to the last case, there's a couple mentions of PULSE or advanced directives. And I'm curious how maybe the use of the PULSE form or an advanced directive might intersect with some of your work in the organizational ethics or policy space.
Absolutely. So a PULSE, we love them. When we've got them, we love them, of course, because this is telling you exactly what the patient would want. At the same time, there are instances in which I would say the patient's body has declared itself as it's multi-organ failure. We've seen a turn, right? So there is a question at some point, and this is why consensus, I think, is so important. If we're still in the space where the patient's values should be driving things, we should be doing that. But there is this little space where no matter what the patient asked for, it's highly unlikely to be effective. Then we need to really figure out what's happening together, multidisciplinary, and go, what needs to happen here? And then be completely transparent if we're making a recommendation. This is also where I think we often talk about, and palliative care talks about, telling rather than asking. Sometimes family members, with or without a PULSE, are like, I can't be the one to say that we're going to discontinue. But if the attending physician says, I want to do this, we're going to do this, then pauses and waits for assent or dissent. So then the family can go, oh, like, okay, I guess, or they can say, absolutely not. If there's dissent, you don't keep moving. But if there's assent, you can use that same strategy to relieve the family of that responsibility of feeling like they said, that person, I decided they're going to die.
That's helpful, thank you. I think if you are up for it, putting your email address in the chat, I think some people are wondering if you would ever consider sharing the policies. And then we have a question from Tyler. He says, back to your early distinction between perceptions of threats and actual threats, do you have a framework for helping us know when something might become violent? So when does language become violent, for instance? When does language become violent? Presumably there are clear times like abusive slurs, but those seem to be the easy cases, so to speak.
Yeah, it's a great question. And Tyler would be the person I'd ask to help me figure out the line. But anyway, but I think in general, something that's uttered with the intention of hurting, to get back to our distinction between intention and not intention, that I think that definitely falls into that category. And discerning that may be difficult. And that's why we give patients more latitude if we don't know how to discern it. And I think we should. But at the same time, the impact may be the same either way. So we can, live in this space of not knowing exactly whether it was intended as mean with the patient while still protecting our staff, I think.
I think we have time for one more question. What are your thoughts about situations in which family or the surrogate reverses the patient's documented wishes?
Oh, well, once again, I think other people on this call may be better able, or more educated in answering it. But this is truly a dilemma. Generally speaking, the patient's own wishes should be guiding to the very end until we maybe hit that point where no matter what we do, the patient's body is failing on us, right?
Second.
But it is really difficult when the team can be really inclined to go with what the surrogate says, particularly if the surrogate is strenuous in their position. And I think whenever possible, we need to uphold the autonomy and the thought out wishes, particularly if it's in something like a POLST, because that's a very thought out conversation. We need to uphold those wishes to the best of our ability.
Wonderful. Thank you. Well, since we've just got 1 minute left, I'll take that minute to say thank you, Dr. Dudzinski, for joining us today and carrying us through some really interesting case studies, examples of organizational policy, where it might fit, where it might not fit. This has been wonderful. And I'll share with everyone that if you
thanks for being here. Kayla, thanks for hosting our previous talk. Denise, for your wonderful conversation and talk to us. I will take the baton to lead the next segment, which I am super excited about. We have the honor and privilege of having Dr. Daphne Marchenko, who's an assistant professor at Stanford University at the Center for Biomedical Ethics, where I will be joining her in a not so short amount of time. So Dr. Marchenko holds MPhil from the University of Cambridge in Politics, Development, and Democratic Education. And in 2019, received her PhD in education also from the University of Cambridge in the UK. Her doctoral work investigated teacher perspectives on the role and relevance of genetic data for education, focusing on how behavioral genetics research on educational attainment and intelligence intersect with educators' conceptualizations of racial and socioeconomic disparities in our American education system. She's appeared in numerous podcasts, including Freakonomics Radio, and had her work published in publicly accessible media outlets like Scientific American and The Conversation. Her work advocates for and facilitates research efforts that promote socially responsible communication of and community engagement with social and behavioral genomics. And as we've gotten to know each other, I'm just really pleased that she was able to give this talk. And one of the wonderful things about the Kinsman Conference is we oftentimes can have these sort of jumps between clinical ethics and organizational ethics and bioethics more broadly. And I think that this talk will really give us a wonderful new flavor for this portion of the day. So without any further ado, Dr. Marchenko, thank you for joining us. I'll moderate the chat, and then when you finish the talk portion, I can help facilitate Q&A.
Sounds good. Thank you so much. And thank you everyone for having me. Hopefully I am sharing slides. Can everyone see them okay?
Yes.
All right, great. Yeah, so thank you so much for having me. This is not the typical conference that I attend, so I feel really fortunate to be able to be here. Thank you for having me, Tyler and Kayla. I'm really excited to be in conversation with all of you and to workshop this idea that I've been thinking through and which hopefully will ultimately end up in a book chapter for a edited collection by Keisha Ray, who is a clinical ethicist, medical humanicist down in Texas. So first, I have no conflicts of interest to disclose, and I'm really focusing today on talking through and meeting a couple of objectives. The first is to analyze how social narratives operate as a social determinant of health. The second is to discuss the concept of social determinants of health more broadly and to understand its function and value in American medicine today. And then finally, to understand how historical and ongoing social narratives impact the health, the wellness, and the flourishing of people. I'm going to be using Slido today. It's an interactive polling feature, and I thought we could just have a little warm-up exercise where I hear from all of you around your thoughts on what comes to mind when you hear social determinant of health. This could be specific social determinants of health. It could be adjectives that come to mind, but you can either go to slido.com and put in that series of numbers, or you can scan the QR code using your phone or some other device, and just start populating with your ideas here. And it looks like people are starting to type. Okay, I hear upstream, race, lack of equity, race, gender, economic status, income, poverty, fairness. Poverty coming through for a number of folks here. Where I live and what I eat. Natural supports, access, Maslow. I'm assuming that's Maslow's hierarchy of needs. I see someone also put into the chat rural versus urban and air quality. Barriers to care, environment, privilege. Fantastic. 80% of health outcomes, addiction, sadness, historical trauma, justice. Someone put in the chat gender identity. I see health literacy and moral obligation as well. Great. Looks like we've got a couple people still typing here. It seems like poverty, structural competency, neighborhood, barriers to care, class, environment, ACEs, mental health coming through as common threads for everybody, or many people at least. Yeah. Okay, wonderful. Thank you so much for sharing those reflections on what comes to mind when you hear social determinant of health. So I'm just going to ground us by providing one definition provided by the World Health Organization for social determinant of health as non-medical factors that influence health outcomes. So they are the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. These forces and systems include economic policies and systems, development agendas, social norms, social policies, and political systems. And what I want to argue today is that social narratives can operate as a social determinant of health. And I'll talk more about what I mean by social determinant or social narratives. But many people might be familiar with this figure produced by KFF, illustrating some social determinants of health, grouping them according to things like economic stability, neighborhood and physical environment, education, food, community safety and social context, and healthcare system, and really focusing on how these social determinants of health, how things like employment, health coverage, many of the things that you all identified in that word cloud affect health and well-being, affect mortality, morbidity, life expectancy, healthcare expenditures, health status, and functional limitations. And what I'm hoping we'll get a sense for by the end of our time together is how social narratives about people, about their capabilities, and about human difference cut across all of these different categories, and providing some examples of it throughout. When Tyler and I met and were talking through prep for this conference, he emphasized that, this is really an opportunity for folks to get to know each other and to get a sense for who you are as a human being and not just as an academic researcher and scholar. And so I thought I would talk a bit about my journey and how that has led me to be really interested in social narratives and the impacts that they may have on people's health and well-being. So my undergraduate degree is in medical anthropology and Slavic studies, a perhaps unconventional combination. But during my undergrad, I started working for an education nonprofit based out of the Bay Area, and really became interested and passionate about educational equity and wanting to help to bridge opportunity gaps that exist for so many children here in the United States. And that led me to pursue an MPhil, as Tyler mentioned, in politics, development, and democratic education, and then to go on to a PhD in education. After that, I ended up working for a nonprofit doing consulting and education policy work. And those interests then led me back to academia, where I did a postdoc in the ethical, legal, and social implications of genetic genomic research and bioethics. And now I'm an assistant professor of biomedical ethics. So I've had a fairly nonlinear path, so to speak, when it comes to the work that I do now, investigating ethical, legal, and social implications of human genetic genomic research. But throughout all of this work and throughout my own experiences growing up, I've become really interested in social narratives, in the ways in which we construct stories about ourselves and others. And as one illustration of this, as was mentioned, I have this PhD in education, and as part of my work, I worked with educators in K-12 schools in the greater Chicago area. And as a thank you to them for volunteering their time and energy to my research, I volunteered in their classrooms. And so one day I was volunteering in a 5th grade classroom for a teacher, a social studies teacher. And the students were doing a reading on Katherine Johnson. If you are unfamiliar with Katherine Johnson was one of the human computers who helped to calculate the trajectory of launching the shuttle for the first person into space. She's an African-American woman, and if you saw the film Hidden Figures, you learned a bit about Katherine Johnson's story. The school that I was volunteering at that day is a public charter school. Over 90% of students were on free and reduced price meals. Over 95% of students in the school identified as Black or African American. And the students were creating mind maps to summarize the reading that they had just done on Katherine Johnson. And this is the mind map of one 5th grade student, a young girl. And you may have already noticed where I'm going with this, but there was a particular element of this mind map that stood out to me when I was looking through it. This student had taken away from reading about Katherine Johnson, just because you're Black, you can be smart. Now, this is just a turn of a phrase, but it signifies an understanding from this 5th grader that by society, Black people are not often considered smart or capable. And she saw Katherine Johnson as a deviation from the norm, as someone who kind of was challenging these social understandings of what it means to be Black. So I've long been interested in how these kinds of narratives get constructed, the impact that they have on the world. And I want to highlight some of the work done by my colleague, Keisha Ray, who is the person that I mentioned that's putting together this edited volume in which this book, this chapter, this idea will appear as a chapter. And to say that this work really builds on some of the work that Keisha has done, talking about how listening to people's narratives provide data on their health and healthcare. And I'm emphasizing here that in addition to the idea that stories can serve as data that can help us with the provision of more humane health and healthcare, that also stories themselves help to create the situations in which people are living. And I want to go through some examples of this. So when we were looking at that bigger chart of social determinants of health, one domain was education, things like literacy, language, vocational training, higher ed, and the impact that education can have on people's health and well-being. And one way that I see social narratives intersecting here is the impact that teachers' perceptions can have on their students. And this is something that I focused a lot on during my doctoral work. But teacher perceptions have visible effects on student performance in the classroom. They impact pupil academic achievement. They impact the educational opportunities that children seek or are provided. And the education outcomes for quote unquote at-risk children, so in particular, racially defined minority students, low-income students, disabled students, are disproportionately and adversely affected by teacher perceptions. Teachers can influence students' self-beliefs through how they grade them, and how teachers in the US grade exams suffer from gender and racial bias. So these different factors, these different elements of the educational experience can have sustained impacts on academic achievement, on the courses that students select in high school, on their journey into higher ed. And in both my MPhil and my PhD, I worked with teachers and I saw examples of teacher perceptions of students and their abilities. You know, I had a teacher that I worked with say, I think some people are ahead in the game, some people have those great genes. I had another say, I can go with Carol Dweck, who is one of the people to coin the notion of the growth mindset. I can go with Carol Dweck for a certain amount of time, but I think sometimes people are inherently good at things and some people will never achieve. So some illustration of teacher perceptions, which we know from the literature do have an impact on students' beliefs about themselves, the classes that they might go on to select, their journey into higher education. And we know that education is a social determinant of health, that adults with more education live healthier and longer lives compared to less educated peers, that many health outcomes have been found to be strongly patterned by education, that education increases the chances that a person accesses quality healthcare, finds employment that pays a living wage, and lives in a safe and non-polluted environment. Education is strongly associated with life expectancy and morbidity. And what I hope that has come across is teacher perceptions of students do have an impact on the educational trajectory of those students, and that educational trajectory in turn has an impact on their experiences of health and well-being. Another example that I want to go over is in relation to the healthcare system. All of us here know that things like health coverage, access to linguistically and culturally appropriate and respectful care, and quality of care impact the health and well-being of individuals. And I'm sure that we all know that clinicians' perceptions of their patients also matter. And I want to talk through some examples of this. I'm going to go way back and provide a historic example. This is in relation to the yellow fever epidemic of 1793 in the city of Philadelphia. And in 1748, so several decades before the outbreak of the yellow fever epidemic, a South Carolina physician named John Leining raised the idea that African Americans were not susceptible to yellow fever. He said, there is something very singular in the constitution of the Negroes which renders them not liable to this fever. And over time, this belief that yellow fever was a disease to which Black people were immune because of their race took hold. It became fodder for slavery apologists, and as we'll see, it played out when the yellow fever epidemic of 1793 took place in the city of Philadelphia. The physician John Leining's claim about the innate racial immunity of African Americans to yellow fever was so enduring that it was repeated. It came up again when the yellow fever epidemic struck in Philadelphia. And the well-known anti-slavery activist and physician Benjamin Rush repeated this claim, but also incorporated it into the logic that he used when he wrote to Richard Allen, who is the image on the right. When he wrote to Richard Allen, who was a founder of the Free African Society, asking if him and the other Black inhabitants of the city of Philadelphia would stay behind and help during the epidemic. And Rush assured Allen that yellow fever would quote, pass by people of color. And in fact, Allen, after some deliberation with other leaders in the free Black community, agreed to Rush's request to stay in the city to help with the epidemic recovery efforts, only to, of course, learn that they were not immune to yellow fever. Allen, for instance, contracted yellow fever but recovered. And Absalom Jones and Richard Allen together wrote a piece in which they said the public were informed that in the West Indies and other places where this terrible malady had been, it was observed that the Blacks were not affected with it. Happy would it have been for you, and much more so for us, if this observation had been verified by our experience. So an example here of how a social narrative about Black people being immune to yellow fever then resulted in greater loss of life within this community. Okay, I'm getting a little request for someone to annotate. I don't know if I should be permitting that. Okay, I'll go through another example here, which is more contemporary and folks may be more familiar with racial bias in pain assessment and treatment. A study was done to show that a substantial number of white lay people and medical students and residents hold false beliefs about biological differences between Black people and white people. For instance, holding perceptions of Black people's skin as being thicker than white people's skin, or perceptions of Black people as drug seeking. And these beliefs have been shown to predict racial bias in pain perception and treatment recommendation accuracy. And we saw that when the opioid epidemic broke out, that this was a rare case in which racial biases actually protected African Americans. And in particular, we saw that African Americans received fewer opioid prescriptions. One reasoning or one thought behind why this was the case is because, as was outlined in this article, Black people, there was a perception that Black people were more likely to become addicted to drugs, or would be more likely to sell the drugs, or had a higher pain threshold than white people because they were biologically different. So again, this idea that there are biological differences between racial groups then affecting how people treat people from different populations, different communities. I also want to talk about the role of social narratives in relation to community safety and the social context. People's perceptions of themselves and each other matter. The people within our community, their perceptions of themselves, their perceptions of their fellow community members matter. They have an impact. And as has already been mentioned, a lot of my work has focused on the ethical, legal, and social implications of genetic genomic research. I'm really interested in claims regarding biological or genetic differences and how they have been used for nefarious purposes. This is where a lot of my work centers. And I'm partially interested in the idea of genetic difference and how narratives about genes filter through society, because genes are seen as sources of promise and peril. They are objects of fear and fascination. Siddhartha Mukherjee, in his book, The Gene, described the gene as one of the most powerful and dangerous ideas in the history of science. We tend not to process information about genetic attributions in a rational or an even-handed way, and we can often think of genetic attributions as being fixed, immutable, and dividing people into homogeneous and discrete groups. And I wanted to provide some examples of how these ideas of genes as being fixed, immutable, or dividing people into homogeneous and discrete groups has impacted the lives of people in our world, historically and today. So one historical example would be the life of Mildred and Richard Loving. I'm sure that their story is familiar with many people here today, but perhaps I can provide some additional context to it. Mildred Dolores Jeter was affectionately called String Bean by her friends and family, and it was through her older brothers that she met Richard Perry Loving, who was a local drag racing day laborer, 6 years her senior. The couple married in Washington, D.C. in the summer of 1958. And soon after, they returned to their hometown of Central Point, Virginia, which is actually not far from where I grew up and from where my parents live today. They were startled awake in the middle of the night by police officers bursting into their bedroom. They were arrested. Their marriage was declared illegal. And soon after, a county judge sentenced them each to a year in prison. Rather than spend that time in prison, they agreed to pay court fees, which came out to about $350 in present day dollars, leave Virginia, and not return for 25 years. Why was the Lovings' marriage declared illegal? Why were they arrested? Well, the problem was that Richard was white, Mildred was not. They were an interracial couple. And Leon Basil, the judge who first sentenced the Lovings, when he issued his final ruling, he declared, Almighty God created the races, white, black, yellow, Malay, and red, and he placed them on separate continents. And but for the interference with his arrangement, there would be no cause for such marriages. the fact that he separated the races shows that he did not intend for the races to mix. So this idea of there being biological differences between racial groups as one of the core premises behind why people had declared interracial marriage to be illegal, or why the Lovings were then arrested. The Lovings fought to have their marriage legally recognized in Virginia. This battle took them all the way to the Supreme Court. And we see in this critical moment in the rulings a line of questioning between one of the Supreme Court justices, Hugo L. Black, who was actually a former member of the KKK, and the defense, Robert McIlwain. And Black starts off by asking, is not the basic premise of these anti-miscegnation laws, these laws outlawing interracial marriage, that white people are superior to the colored people and that they should not therefore be permitted to marry because it might pollute the white race? And McIlwain was forced to admit that this was in fact a key motivation for the law. He says, Your Honor, I think that there is, I think historically that the legislatures which enacted them had this thought in line. So this reluctant admission is that this motivation underlying Virginia's law banning interracial marriage is a key reason why the Supreme Court unanimously decided to strike down such laws. Black and the other Supreme Court justices concluded that these laws did not view members of different racial groups as fundamentally equal to one another because it regarded white individuals as superior to all other racial groups, but especially to the Black and African American community, which this Virginia law had specifically and explicitly targeted. The Lovings legal representative, Philip Hirschkopf, explained that when incepted to keep the slaves, that these laws were incepted to keep the slaves in place, they were prolonged to keep the slaves in their place, and that they still viewed the Negro race as a slave race. And so they were a violation of the equal protection and due process clauses of the 14th Amendment. Another historical example that I want to provide is that of Francis Galton. He was Charles Darwin's half-cousin. He was a man of many trades, but is known for being one of the pioneers of the study of human intelligence, for being a father of behavioral genetics and the eugenics movement. And in 1869, he published a work entitled Hereditary Genius, which gave rise to this conception of mental ability or cognitive ability as being a genetically influenced and fixed trait. Galton was particularly concerned with the decline of genius in society, and so he put special emphasis on encouraging those that he believed to be physically and mentally superior members of the population to choose partners with similar traits. And he said in Hereditary Genius, I have no patience with the hypothesis occasionally expressed and often implied, especially in tales written to children to be good, that babies are born pretty much alike, and that the sole agencies in creating differences between between boy and man are steady application and moral effort. It is in the most unqualified manner that I object to pretensions of natural equality. So this is Galton in 1869. I want to look at how several decades later, this idea of there being inherent differences between people in terms of their cognitive abilities playing out in the life experiences of Carrie and Emma Buck, a daughter and mother. In 1924, Carrie Buck, who is the woman on the left side with the darker colored hair, was admitted to the Virginia State Colony, a mental institution designed to separate so-called feeble-minded individuals from the rest of society. And Virginia, I'm giving a lot of shout outs to my state this morning, my home state, unfortunate shout outs, was one of the first laws permitting or passing legislation permitting involuntary sterilization of the feeble-minded. Proponents believed that such measures were necessary to promote the welfare of society. They feared that the feeble-minded would pass down their alleged low intelligence, their moral degeneracy. And the state of Virginia, arguing that Carrie was a threat to a genetic threat to society, filed to have her sterilized under this new Virginia law. The issue, though, was that this law was, whether this law was going to be considered permissible under the U.S. Constitution was uncertain. And so the colony thought Carrie Buck is a slam dunk example of how involuntary sterilization should be permitted. We're going to basically orchestrate a court case to ensure that there will be no legal challenges in the future to our law on involuntary sterilization. Her case eventually made it to the U.S. Supreme Court in Buck v. Bell. And I should mention that the reason it made it to the Supreme Court is because the defense was were hired by the colony. And although in all of the lower courts, the courts had agreed that involuntary sterilization was permissible, the defense kept petitioning or challenging that ruling all the way until it made it to the Supreme Court, because they knew that if the Supreme Court ruled on it and ruled on it in their favor, they wouldn't have legal challenges in the future. So in 1927, the Supreme Court case Buck v. Bell deemed forced sterilization for eugenic purposes legal in the US. It passed 8-1. And as Justice Oliver Wendell issued in his final decree, he said, "It's better for all the world if instead of waiting to execute degenerate offspring for crime or to let them starve for their imbecility, society can prevent those who are manifestly unfit from continuing their kind." By 1935, all but 6 states had attempted to pass legislation permitting involuntary sterilization. And over the 20th century, 33 states enacted compulsory sterilization programs, ultimately sterilizing over 70,000 women without their consent. And technically, Buck v. Bell has never been overturned. So again, an example of how a social narrative about cognitive ability and the existence of social inequality that is genetically informed led to policy decisions affecting the health of people. I also, because I focus a lot on genetic genomic research, want to talk about how research can be used to bolster existing social narratives or to create new social narratives. And in the genetics community in recent years, there's been a lot of focus on how this research has been used and appropriated by members of white supremacist and alt-right groups. Most notably, in May of 2022, the scientific community was horrified to learn that in the Buffalo shooting, in which 10 African Americans were killed by a white teenager who had driven in from out of town, that individual, the shooter, had issued an over 100-page manifesto in which he cited a number of genetic studies as evidence of the superiority of white people over Black people. So in particular, the shooter cited a 2018 genetic study on educational attainment, how many years of schooling a person completes in their lifetime. This was a paper that was published in Nature Genetics, and included in his manifesto a pseudoscientific table allegedly evidencing that this study had found that specific genetic variants associated with educational attainment were more common in Europeans, which he then conflated with white individuals, than with Africans, which he conflated with Black individuals. And I just briefly want to go over how it is that a 2018 genetic study published in Nature Genetics ended up in the manifesto of the Buffalo shooter who carried out a racially motivated series of murders. So less than 6 weeks after this study was published, the following appeared on 4chan, an internet message board where users can post anonymously. It's popular it's a popular messaging forum for far-right extremism, and I'll just zoom in on one element of that post. But a user says, "I found groundbreaking genetic evidence for racial differences, but I can't do anything about it. If someone here is a scientist, go run the numbers and get it published at the risk of ruining your careers, but saving humanity. There's a study that has thousands of genes associated with intelligence listed in their supplementary data. They studied 1 million individuals. Not only are the correlations insanely strong, but most of the genes codify for the nervous system, so it's almost undeniable." And what, just very briefly, what this individual had done was they cross-referenced the genetic variants that had been identified in that Nature Genetics study with a publicly accessible catalog of genomic data called the 1,000 Genomes Project. The 1,000 Genomes Project is a database comprised of samples from approximately 26 different ancestral populations from around the world. And about 2 hours after that original post, the user then created and shared a table purporting to show 15 variants that were, quote, known to increase intelligence, and that they had concluded were more common among Europeans than among Africans. And they say the data is pretty damning when you check the effect sizes. I don't have time to do much more than this. I only checked one of the tables in the study. There's easily over 200 genes like this. So over the next 5 days, the table was updated, it was reposted in a number of different 4chan threads, and eventually a user posted an updated version that listed more than 200 genetic variants. And over the next 4 years, this version of the table was reposted more than 5,000 times on 4chan. It appeared, this is the table that appeared in the manifesto of the Buffalo shooter. And my colleague Jed Carlson is the brains behind tracing the origins of the EA3 table, as it's kind of informally called, the Genome-Wide Association Study. And Jed has also shown that the Buffalo shooter is just one data point in a much larger trend, demonstrating that the posting frequency of scientific memes like tables from the last slide increase following shootings and political events. So this weaponization of genomic research, it of course raises questions about how we should publish our studies, where we should publish our studies, and what it means to practice social responsibility as a researcher. But it's also an illustration of how research can get used to bolster existing social narratives about human difference. How we educate people can also bolster existing social narratives or create new ones. And Brian Donovan is an incredible scholar who has shown how our ideas about human difference get really formed at a young age. So he's found that between ages 5 and 10, evidence suggests that US elementary schoolers stop thinking of racial identity as subjective and flexible, and they begin thinking of it as natural and stable. And that adolescence is when people begin to favor genetic explanations for racially stereotyped traits like intelligence and athleticism, rather than the environment or choice. And Donovan goes on to say, if instructors teach genetics to help students understand the flaws of genetic essentialist arguments, then it is possible to reduce belief in genetic essentialism among biology students. And taking this to heart, he has started through NSF funding, building what he's calling humane genetics, trying to revamp the high school biology curriculum to teach more about the complexities of genetics, to try and disrupt these genetic determinists or racial essentialist narratives that we hold about human beings and sources of human difference. So if we think back to social determinants of health as non-medical factors that influence health outcomes, as being the conditions in which people are born, grow, work, live, and age, and as the wider set of forces and systems shaping the daily conditions of life, then hopefully we can now see how social narratives about people, about their capabilities, and about health, human difference can operate as a social determinant of health. How social narratives intersect with people's experiences in their neighborhoods and physical environments, their experiences in education, their experiences as it relates to community safety and the social context, and of course, as it relates to their experiences in the healthcare system. So in summary, long-standing social narratives exist about people, their health, their well-being, and their capabilities. And long-standing social narratives exist about the origins of human difference. Research can be used to bolster these narratives or to create new ones. How we educate people can bolster existing narratives or create new ones. Clinicians, educators, our own perceptions of each other all matter and affect people's health and well-being. Social narratives shape the conditions of daily life, and they have real-world repercussions, even if these narratives are myths and not grounded in fact or truth. They have real-world repercussions for people's health and well-being. And so identifying and understanding the role that social narratives can play as a social determinant of health, I think can bring some attention and urgency to dispelling misconceptions that can have life or death consequences. Identifying, investigating, and addressing social determinants of health, including the social narratives we construct as a society, is vital to building a more humane system of care. So with all of that, I wanted to take some time and ask you all what kinds of social narratives you might see in your own workplace, your own life, neighborhood, community, that you see or can see acting as a social determinant of health. Using Slido again here. Looks like people are starting to type. This is an open text response, so it might take a little bit longer for this to get populated. The idea that certain groups are more resistant to standards of care. The idea that being homeless means you do not care about yourself. The myth of personal responsibility. The idea that unhoused patients were meant to be that way and it won't change. The idea that poor people are just plain lazy, or assuming that houselessness means mental health problems, or that substance use is a choice, or that people don't recover from addiction. The determination and makeup of in-groups and out-groups, that all those in prison or jail deserve to be there and have lower value to the community, or that substance users are not worth the energy in trying to help them change. Apprehension of Black people on health advisories such as vaccines. Working in peds, patient families of color are more labeled on the unit as difficult, aggressive, non-compliant compared to white families. Or that the resiliency of certain communities confers health-related benefits to its members. See narratives about people who don't speak English as a first language or speak an accented form of English per American standards. That people have choice in their adherence to medication or appointments or treatment. That Black folks' reports of pain are thought to be drug-seeking behaviors, or that single parenthood is bad for children. I see in the chat someone talking about EGFR, assuming that very elderly have dementia or are not capable, or that folks with disability don't have decisional capacity. Good, and as you can see at the top, there are some threads in terms of themes that people are raising in terms of the social narrative. So people talking about homelessness, substance use, choices, imagining that LGBTQIA+ people or certain races are hypersexual, assuming people with speech impediments are less intelligent or less able to engage in their healthcare individual, or that Big Pharma does not want to cure disease in poor people, that body size is a matter of choice or willpower, or that mental health is a choice. Thank you everyone for sharing these. These are, yeah, I think really important to keep in mind, not just their existence in society, but the impact that they have on health and healthcare and well-being. Thinking that girls and women can't do math or science or medicine well. See movie 23rd. Well, I'm hoping that this activity is a good prompt for the discussion. This is all that I've got for the formal part of the hour that I've been allotted, and I'm hoping that we'll have plenty of time to just talk with each other, and I'd be eager to hear folks' thoughts on this as an idea that I'm kind of fleshing out in my own thinking. Yeah, I see low health literacy or trouble understanding are burdens that patients must bear rather than a failure of healthcare to communicate clearly. Or that being a healthcare professional makes you smarter than your patients. Yeah, great. And I'd be happy to find a way to share this with the Kinsman organizers if folks want to get this list after the conference ends.
Well, we would love that. Yeah,
please,
if you can copy that and send it to Dave Hoyt, he can disseminate it or post it perhaps on our website along with where your talk will be posted as sort of a drop down, an adjunct. Goodness, thank you. I'm getting text on the side too, just being like, oh my gosh, my mind is being blown, which is always a good indicator. I think your talk hits very close to my heart. It makes me more excited for us to be able to work together on the ways that these narratives of the self sort of construct our reality, and what we take for granted. I think while people are, please start formulating your questions and typing them in, and I'll curate them. And in the meantime, I have one question. It's sort of two questions, but they're very much related. As sort of a pushback against these damaging narratives that you've so sort of clearly showed how they structure just how we think about the world. When you, as a researcher, when you're conducting new research, do you, one, how in the structure of your research and as you construct your methods, do you attempt to fight back against this, I guess, is part A. And then part B is, do you think you should? Like, is that your responsibility, or does that somehow, the idea to counter these damaging narratives, if you try to put those in your very methods, does that actually undercut the reliability of your results?
Yeah, those are both such great questions. And I have a few thoughts. So one is, I'm currently writing a book with a colleague that we've tentatively titled "The Acid We Inherit," and the kind of whole argument, the argument that's at the heart of the book is that when we think about DNA and genetics, people are primed to think about, the literal acid that's in our cells, the A's, T's, C's, and G's that comprise the DNA helix, but also that there are these genetic myths that exist that also get passed down by generations and inherited within our society, and that we need to think about the role of these narratives in the world. And so in this book, one of the things that we do is we explicitly talk about genetic myths, things like racial essentialist narratives or genetically determinist narratives, and debunk them. We kind of deconstruct them. We show them for what they are, ways to try and maintain the status quo and power hierarchies within society. But I think one of the other points that we make here is that, yes, researchers, physicians, clinicians, people who are in these positions of privilege have a responsibility to counteract these harmful narratives. And I think, again, I'm going to answer this specifically within the domain of genetic genomic research because that's where a lot of my attention and focus is. But we see that sometimes researchers feel like or argue that their research is creating, a new narrative, a new story, that the data is pointing in a new direction that's going to dispel these harmful narratives, but they're not actually explicitly targeting those narratives. There's kind of this optimism that my data is going to tell this new story, and because it exists in the world, it's going to outpower these longstanding historical, pervasive, durable ones that have been around. And so I feel very strongly that we have a social responsibility to explicitly try and counteract those myths. And I'll say that I think that in terms of research, there are different various ways to do that. So it doesn't have to be just that it happens in an academic manuscript, because again, how many members of the public are going to go read that academic journal article to begin with? It matters in terms of how we communicate with media journalists. It matters in terms of how we respond to industry applications of our research. It matters in terms of how we ourselves communicate with members of the public and whether we communicate with members of the public. So I think that dispelling narratives doesn't necessarily need to happen when we're publishing our academic manuscript itself. And also, that might not even be the most effective place for us to be doing that. And so, for instance, I had mentioned Brian Donovan as a scholar who works to show how genetic literacy and building genetic literacy among students can help to dispel these harmful narratives that exist. He is doing both research to demonstrate the phenomenon, but then also research to figure out how do we disrupt it. So I say that because I think there's also a place for building out research trying to answer this empirical question, really, of how do we dispel these narratives and what might be the most effective approach to doing so.
Thank you. That's really helpful. It's just, I mean, I think your talk has made me just, my mind is going to all the places where the idea of the gene has shown up in people's lives to kind of give them this sort of determinative set of reasons for why certain things are taking place. I just had a patient yesterday. I was on service who, when we were talking about their really neurologically devastated baby in the neonatal ICU, trying to talk to him about getting why a trach was going to be required, and he responded with a story about several family members who had recovered from very small things like being cross-eyed and were now quite healthy today. And then he just looked me right in the eye. He said, "We've got good genes. He's going to get better." Like, what a narrative to sort of completely structure the way that this clinical encounter was going. There were a lot of good questions. I kind of riffing on one that's a little bit higher up, either personally or from a research perspective, how has social media and just the whole way that our storytelling and the way we gain knowledge has changed in the last 10 years impacted the way that these narratives kind of course through our consciousness and our communities? I don't know what's happening with this sharing, screen share. Whoever, Eric, I think you just shared your screen. Please don't. How does that change how this goes? And I mean, because you might think that in the past narratives didn't have the same kind of uptake, but with your research, you've shown these various examples where there was no social media and didn't stop these narratives from proliferating in society. So how do you think social media and other forms of media have changed that?
Yeah, I mean, I think to some extent social media has accelerated the ways in which these narratives can circulate. I mean, the example that I had presented around the Buffalo shooter and how that pseudoscientific table ended up in his screed, the table came to exist about 6 weeks after the study was published and entered out into the world, and then circulated thousands of times on 4chan. So I think there's an acceleration in terms of how these kinds of narratives can circulate that social media is helping to facilitate. But I think on the flip side, that also means that social media can be used as a way to help and dispel or call out those false narratives. So Jed Carlson, the colleague that I had mentioned who had traced the origins of that pseudoscientific table, also does a lot of work spending time on 4chan, spending time on Discord, mapping how the information gets circulated and what exactly is getting circulated, and sometimes does the really uncomfortable, unpleasant work of trying to directly engage with folks and call out harmful ideas that may involve people using his own research as evidence. So I think there's also a kind of flip side to the accelerant aspect of social media.
Mm-hmm. This one is one I was just thinking about throughout your talk, and I don't know how much you've studied it, but just in terms of how do you change your mind? So fantastic talk. Changing attitude is really hard. How can we help communities and ourselves change for the better?
Yeah, that is such a good question, such a difficult question. I've been thinking about this a lot because, in this particular area of genetic research that I focus on, it's highly controversial and there's a lot of debate about it. And I'm starting to feel like the first step is just bringing people to the same table, having them be in conversation with each other. And one of the reasons why perhaps that doesn't happen at the frequency that it should is there's this pressure to achieve consensus over just trying to understand each other to begin with and where we're coming from. And I understand that for medical professionals, that is very hard to do because time is so limited. There are so many demands that are placed upon you, that taking the time to sit down and try and understand someone and where they're coming from is not going to be the easiest thing to do, and may require decisions about other aspects that are going to have to wait till later or to make, room. So I understand that it's not going to be an easy solution to take the time to just listen to someone without necessarily having an objective explicitly stated coming in to that encounter of wanting to convince somebody or to get somebody, to agree with you or to be on your side. And I've been thinking about this in relation to genomic research on human behavior, because there's a lot of talking past rather than with each other. And one of the results of that is we see industry applications of these genomic data that are premature, that are unvalidated, that could be harmful to people. So how do we bring people into conversation and remove the pressure to achieve consensus as a first step to just understand where we're coming from and what we mean when we use a specific phrase or term? Oftentimes I find that we can think we mean the same thing, and it's only until much further on in the conversation that we realize we have different understandings of this term that we're both using.
Thank you. That was really helpful. Here, this is a question I had that's a bit of a change. I don't know how much you've thought about this, but it's really a normative ethical question, which is, the idea of free and open discourse sort of goes back to Mill, that we should be in a liberal democracy. We should be free to learn and say and speak kind of everything, and that's how we grow. With something like 4chan, and this ability to just create these wormholes of misinformation, have you thought much about kind of the politics and legality of this sort of free and open discourse, which seems to, sort of Twitter is a great example of all the legal challenges and the back and forth with Musk of trying to think about how much free speech should we allow. Have you thought about that in relationship to these social narratives that can obviously be very damaging to the very health of the democracy that this so-called free speech is trying to support?
Yeah. Oh, another really hard question. You're giving me lots of hard questions.
We just want to hear you talk because it was such a great talk. So
I think that I would say I've thought about this in a very narrow sense, which is trying to go more upstream in the process, because I've been very interested in, how does research get used to bolster harmful narratives when the research itself is making no claims related to that at all. And so thinking upstream of, how might we even try and prevent a situation where you end up with that 4chan discussion post that results in that pseudoscientific table. So I think I've been thinking about this question of freedom of speech kind of further upstream in the research process in the domain of academia, where we're in this environment of wanting to support open access and data sharing. And there are lots of really important reasons for wanting to help to facilitate that. We want, scientific and technological progress. We want people to be able to reproduce colleagues' results in the spirit of rigor of research. And I think that there are ways for us to try and facilitate those aspects to data sharing while also trying to safeguard against information being readily available and accessible to folks who may have nefarious intent, or who might not use that information in ways that are reflective of what the information actually is saying. So I think I've been thinking about the freedom question more in the domain of maybe academic freedom and how data and information gets circulated and shifted, to try and think of ways in which the harmful discourses that happen in social media don't have a foot to stand on when it comes to the scientific evidence. But I have not thought about what I think your question was really asking, which is around how do we think about just all the harmful discourse that gets circulated on social media, and trying to weigh the achievement or the support of freedom of speech against the potential harms that speech might cause. I haven't thought about that as deeply, and there are lots of other way more qualified people who have.
Well, in time, I imagine you will too. Okay, last question that Kayla asked, just very kind of more a practical clinical question. As you broaden your work in the medical setting, how do you, and obviously you work with a lot of people who work clinically, how do you teach these important takeaways to medical professionals in particular? Any advice for those of us who will bring back what we've learned today from your talk to our colleagues?
Yeah, thank you. So I do some work with genetic counselors and with medical genetics and genomics residents. So maybe I'll preempt it by saying I have a genetic counseling student that I worked with who was very interested in medical genetics and genomics residents and their perceived gaps in knowledge as it relates to navigating race and racism related issues in clinical practice and care. And one of the real standout messages from that qualitative interview study was that the medical genetics and genomics residents we interviewed didn't feel like they were equipped to navigate those issues. And not only didn't feel equipped to navigate race and racism related issues in the provision of medical genetics and genomics clinical care, but felt like it was a taboo topic within their residency programs, that there wasn't appropriate education on these topics, and that in fact it was something that they didn't feel comfortable bringing up with their attendings or with their professors as something that they felt they weren't getting sufficiently trained on, and also that if they saw an attending engaging in a behavior that they considered to be culturally insensitive or inappropriate, that they didn't feel comfortable being able to point that out or raise that. So I think kind of as a first step, I talked about the importance of education, and I really do believe that education is really important, and that we're seeing examples of trainees not feeling like they're getting the appropriate education that they need to be able to provide humane clinical care. So I think that's kind of one aspect to this that's really important. And the other thing that I'll say is, in trying to think through how do we revise the ways that we educate our trainees, that is going to involve us also having very difficult conversations about what is it in the existing curriculum that we need to remove or alter or condense to make space for this training. And I want to acknowledge that, because I think simply saying we need more education on this is necessarily going to entail that we have to make difficult decisions elsewhere in the curriculum about what to teach and how to teach. So I hope that that's a sufficient enough start to an answer. I know we're at time.
That's a fantastic answer. Thank you. Well, everyone, please give Dr. Marchenko a round of applause. Thank you for that absolutely thrilling and stimulating talk. And I imagine all of us will watch that talk again and look forward to reading your research in this book chapter when it comes out, as I know it absolutely will.
Thank you.
Thank you. All right, everyone.
Let's get started. As you heard in the intro, my name is Kayla Tabari House. I'm a clinical ethicist at Providence Center for Healthcare Ethics. And as I mentioned this morning, I have the fortune of co-chairing today's conference with Dr. Tyler Tate, as well as the pleasure of presenting our afternoon plenary with Dr. Laura Mabity. So I'm going to take a moment here to introduce Dr. Mabity. She's the clinical director of St. Charles Health System's palliative care program, and she's also the medical director of St. Charles Home Health and the division director for post-acute care for the St. Charles Medical Group. Dr. Mabity is a board-certified physician in hospice and palliative care medicine and internal medicine, and she's practiced in hospice and palliative care medicine since 2005. She started St. Charles Health System's palliative care consultation service in 2009, which has since expanded into a comprehensive regional palliative care program. She has served as the chair of the Bioethics Committee for St. Charles and remains an active member of the committee. Dr. Mavety has been a speaker at multiple regional, state, and national conferences focused on palliative care topics and has supported efforts to promote palliative care access at state and national levels in partnership with the American Cancer Society's Cancer Action Network. Dr. Mavety served as board member for the Oregon Hospice and Palliative Care Association and on the Interdisciplinary Quality of Life Palliative Care Council for the Oregon Health Authority from 2016 until 2019. Dr. Mavety completed her internal medicine residency and hospice and palliative medicine fellowship, both at Oregon Health and Science University and the Portland VA. Such a joy to get to co-present with you, Dr. Mavety.
Right back at you, Kayla. I have to say, being able to come to the Kinsman is always very much enriching for many of us. And I'm feeling especially connected because I'm getting to cross paths today virtually with many of my colleagues who are much more so of ethics experts around our state and in our entire region here in the Pacific Northwest. Kayla and many others have helped me personally with some really important ethical issues that we've been trying to deal with here at St. Charles Health System, just like many of our health systems. And so I can't tell you what an honor it is to get to be included in our incredibly knowledgeable speaker panels today. And I'm really honored to get to present what we hope is a very enjoyable session for you. This brainchild was very much Kayla's, and in struggling together, you have now in front of you an ethicist, as well as a palliative care doc. And so in thinking through these challenging cases, I think really we're hoping that having an ethicist and a palliative care clinician is helpful for you. So I am going to do just a brief bio introduction for Kayla. As you know, as our co-chair for today's conference, she's a clinical ethicist for us at Providence Center for Healthcare Ethics. Her role includes conducting clinical ethics consultations, which again was so fruitful for us with putting this session together for you. And she provides those consultations across Providence, Oregon, as well as providing ethics education to physician residents as well as healthcare staff. She began her career as a labor and delivery nurse, where she specialized in therapeutic communication during perinatal loss. Kayla holds a master's in bioethics from Harvard Medical School, a Bachelor of Science from the University of San Francisco, and is a PhD student currently at Duquesne University. Her research interests are focused on life's most powerful transitions, particularly childbirth and end-of-life care.
Thank you so much, Dr. Mavety. Shall we get started?
Let's do it.
Wonderful. Well, first, neither Dr. Mavety or I have any disclosures to report today. I do want to make a disclaimer that we're going to discuss cases today that touch on end-of-life, abuse, trauma, and other complex issues. And if you're not in the headspace for any of those topics, please do feel free to hop off this call, take some time to care for yourself. No hard feelings here. I did also want to mention that all of the patient names and cases, while they are based on real cases, please rest assured that they have been changed and de-identified for the sake of patient privacy. Last but not least, final request of the day, I promise. Please take out a pen and paper, if you will. You are also welcome to use the chat, but we thought this would be fun as kind of a solo exercise. We're going to ask you to note any ethical issues you identify after we share each case. So we're going to talk about 4 really interesting cases today, but we're also going to zoom out a little bit after those cases. There are so many ethically complex cases that medical teams face on a daily basis. I'll share it was really hard to choose just 4. Today, we're going to talk about these 4 different cases, and then afterwards, your breakout groups are actually going to correspond with each case. So there's 4 cases we'll talk about. You'll be in 4 breakout groups. So when you go to the breakout group, you're going to pick just one, right? and that one will deep dive into one of the 4 cases that we've highlighted here today. So we're going to talk about complex disposition. Another way to think about that term is, what do you do when a patient is medically cleared for discharge, but we have questions about where do they go next? Another thing we're going to talk about is repeated foreign body ingestion. The abbreviation for that is RFBI. And for folks wondering, what does that mean? One way to think about that would be patients, for example, who repeatedly swallow objects or ingest objects. The third case will be centered on decision-making in pediatrics. We're going to look at a case where we're going to talk about death by neurologic criteria as it pertains to a minor. And the last case will be focused on guardianship and surrogate decision-making and sort of the complexities around when is guardianship the right choice.
So as Kayla highlighted for us, we're going to spend this hour trying to present these 4 really challenging cases that have been gathered from our colleagues from around the state. And so clinicians who've experienced cases like these came forward, and these are the kind of cases that keep us up at night when you're in the middle of one of them. So we're going to spend time going through each of these at a high level. And like Kayla said, we're going to do the deep dive in the breakout sessions. So we won't get too far into the deep dive here. However, as Kayla said, we'd love for you to really think through some of the ethical issues that crop up for you as we go through these cases together. And so, and then we'll provide a little bit of our own ethical issues that arose for us. Not that they're necessarily complete. I bet you all will have a lot more ideas that'll complete out the entire picture. And please be ready to bring those to your breakout sessions. So we'll get rolling then on our first case. So this is a case of complex disposition. And this case comes from our colleagues, Melanie Smith, LCSW at the Portland VA, and Melissa McGuire, LCSW at Asante Health. And the title of that breakout session after this will be Ethical Dilemmas in Complex Discharge Planning. Next slide. All right, so this first case, this is a case of Gary. Gary is a 17-year-old male, and he has a medical history that's significant for autism. At baseline, Gary's nonverbal. He communicates through signing and through use of picture boards, and he manages basic ADLs, but needs reminders to do those. He lives with his mom, his dad, and a younger brother. His mother happens to be his primary caregiver because his father works outside of the home. Gary presents to the ED for behavioral disturbances and is seen in the ED multiple times over the course of several weeks for the exact same concern. Both the medical team and the psychiatry team recommend that he should really be in residential placement. Gary's mother discloses to the medical team that she will often have to lock Gary in his room when he gets agitated. Because of his behavioral disturbances, Gary is typically seen in the ED locked adult psychiatric unit. He's unable to be physically examined without having restraints in place, and he has to have medications to keep him calm enough to be there and to be cared for. He becomes very physically violent towards staff on multiple occasions. Next slide. Gary presents to the ED in early April and is seen by staff who discharge him home. However, this time, Gary's parents refuse to take him home. They share that they're afraid for their safety and for the safety of their other son. Hospital administration does not want to admit a, quote, child that has no medical issues and who cannot be safely managed on a pediatric unit, unquote. Family refuses to speak with hospital administration for days, while Gary is held in the ED locked behavioral health unit. Slide. Hospital administration attempts to send Gary back home via wheelchair van transport with a police escort, but the family doesn't answer the door. Gary is therefore returned back to the hospital. Complicating matters is that Gary's father became so escalated during conversation with hospital administration that he actually threatened the lives of 2 members of Gary's medical team, and a restraining order was placed against him. Okay, there's a case, all right. Please take a couple of minutes to write down any ethical concerns that came up while you were hearing about this case. Okay, hopefully that gave everybody enough time to think of a few things. Next slide, and I'll share with you some of the things that came up for me when I was hearing about this incredibly difficult case. So how are we helping this patient? And big emphasis on the, are we helping this patient? He's been locked in an ED unit repeatedly, and he's stuck there again. Is this the definition of beneficence? Are we harming Gary? Does it matter that Gary's 17 years old because he's a minor in the state of Oregon? What about his autonomy, though? Are we using healthcare resources appropriately for this patient? Are we reusing those resources appropriately for his family? Justice considerations abound. Next slide. So again, if you're interested in hearing more about this case and thinking through some of those ethical issues, you'll join Melanie and Melissa at our breakout session titled Ethical Dilemmas in Complex Discharge Planning.
Thank you, Laura. The next case we're going to sort of tease to you all before the breakout sessions is a case about repeated foreign body ingestion. And if you're interested in learning more about this case, or if this is the breakout group you've signed up for, you're in luck. Dr. Sarah Combs from Providence Center for Healthcare Ethics and Dr. Michael Zelanka from Legacy Emmanuel Medical Center are going to present a deep dive into this case. I love what they've called it, digesting the ethics, exploring responsibility in this space. So we're going to talk about patient D for a minute here. Patient D is a 40-year-old woman with a past medical history significant for repeated ingestion of ballpoint pens, which continues to be the cause of hospital admissions for this patient. 83 endoscopy cases at local hospitals have been performed to remove 91 pens from patient D's digestive tract in the last year alone, and countless cases in the years prior. Oftentimes, back-to-back removals are needed. So what happens for this patient is she might swallow a ballpoint pen, present to the hospital, to the ED, report that she's done so, and a procedure will take place, an EGD or an endoscopy, to remove said ballpoint pen. And then afterwards, in the post-op unit or the PACU unit, unfortunately, this patient often hides more ballpoint pens, and so she'll pull one perhaps out of her sock or shoe or a bag, and she'll ingest another one, and that will kind of repeat the cycle, hence the back-to-back removals often being needed. Patient D, for a little bit more context, is housed, employed, and demonstrates decisional capacity. Many services, as you might imagine, have been consulted to help in patient D's care. Those services include behavioral health, psychiatry, palliative care, ethics, and multiple GI teams. And because this patient presents to multiple hospitals in a pretty small region of Oregon, these teams have been consulted not just at one hospital in particular, but really, ethicists, psychiatrists, palliative care teams in many different hospitals have been involved in this patient's case. As you might also imagine, numerous relevant outpatient appointments have been made on the patient's behalf or lined up for the patient, but she repeatedly states that while she's physically and financially able to get to appointments, which is an important barrier to examine, right, she's simply not interested in going. So when asked more about, sort of the repetition of the ingestion and what's going on, patient D shares that the people who work at the hospitals are wonderful. She really enjoys their company. She started to think of some of the pre-op nurses at different facilities as family. And she enjoys the combination of medicines that she receives from the anesthesia team during the procedures to recover the pens. So she'll often share with the anesthesiologist prior to the case that she's comfortable with, for example, a certain dose of Versed and fentanyl or what have you, propofol, who knows, that would be ideal for her in this case. And she reports that she enjoys the combination of medicines. So the surgery, an EGD, to ensure the removal of pens requires the utilization of quite a broad healthcare team. So we're talking, we need to have multiple nurses there, right? There's a pre-op, intraoperative, and post-operative nursing teams. We need an anesthesiologist, a gastroenterologist. We need an endoscopy technician, environmental services staff to prepare the room and to clean afterwards, and others. I'm sure there's folks here that I'm missing. And then, of course, you need the actual room itself, which is valuable, a medical procedures or endoscopy operating room, as they're called. and then considerable medical equipment in order to perform these surgeries. And what's notable about this case is most of the patient's pen swallowing episodes do occur between the hours of 11 p.m., sorry for the typo, and 3 a.m. So these are very much overnight. I think it's 90 to 95% of the pens that patient D swallows will be between the hours of 11 p.m. and 3 a.m. You might be wondering, why do I care what time of day this happens? Well, overnight, operating room teams are usually not as well staffed. And that's because if you think about a scheduled surgery, you've probably never been scheduled for a routine surgery at 2 a.m., right? The use of an operating room or a medical procedures room, an endoscopy room, any type of operating room overnight is generally with the idea that they're going to be reserved for emergency use or for cases that last longer than 12 hours. And so the medical staff is distressed by how often patient D comes in, but they're also concerned that it takes away from their ability to care for other patients. One physician shared with the team in particular, his concern was that he was, on call as a solo physician managing a number of operating rooms, and oftentimes he might be tied up caring for patient D. And so what might happen to other patients whose care is delayed? And you could argue that, of course, that can always happen when you're thinking about navigating emergencies. You're constantly having to prioritize, right? But there's a sense from the team when ethics and other teams are involved that maybe we spend, quote, so much time, right, unquote, on caring for this patient that we're really not able to care for others in the way that we had hoped. So please take 2 minutes to write down some of the initial ethical concerns you've identified in this case, and then we'll share for you what came up for us. All right. Well, a few things that came to mind for me in thinking through this case is, how are we helping this patient? You'll notice this is kind of a theme in the cases that Dr. Mavi and I present. We're often thinking to ourselves first, how are we helping? Are we helping? Are we hurting this patient? And so while in the literal sense, you might think, of course, we're helping this patient, right? She swallowed a pen. If it's not removed, it could cause some fairly catastrophic sequelae. It could perforate her duodenum, or some other part of her body that could cause all kinds of complications. So of course, like in the literal sense, yes, we are helping the patient by removing the pen. But I think maybe there's a broader question here of, are we helping her in the bigger picture sense, right? Because we can imagine this patient's not always able to sleep through the night. It might be harmful to the patient to experience the pen swallowing episodes. It might be creating challenges for her in life more broadly, in friendships and social relationships. How does she feel, right? That's something to examine. How does she feel about this circumstance that she's experiencing? You could even argue that we're hurting the patient, some would say, by perhaps not setting up boundaries. Or are we obligated ethically, legally, morally to say, listen, if you keep doing this, we're not going to intervene, or we're going to intervene less, or how we intervene might look different. So there's a lot of really tricky questions that come up in this case. One that I found to be quite salient was, how do we honor this patient's autonomy, meaning her freedom to do as she pleases, right? And if that's swallowing a ballpoint pen, then so be it. But we also want to balance that with setting limits, knowing that it might not be feasible or perhaps ideal for a patient to undergo this number of surgeries and this amount of anesthesia on such a regular basis. We also are kind of wrestling with resource allocation here, right? So when we think about resource allocation, we're thinking about making ethically complex decisions regarding how to best use the resources we have. And of course, we have the resources in some sense to remove every ballpoint pen that is ingested. But on the other hand, we know that other patients' care might be delayed because folks are tied up in this patient's care. And so we might want to think about, is the resource, not just the operating room itself, not just the surgeon themselves, but also the whole nursing team, the broader medical groups that are caring for this patient, how are we using their time? And I will share quickly before we go to the next case that one thing that stood out to me in this case was folks on the medical team were reporting that they knew this patient would come in. So when they were on call overnight, they would sit in their cars in the hospital parking lot, wait for her to ingest a ballpoint pen. Because she would do it repeatedly after the case, they wouldn't drive home. They would go back in their car, sit in their car and wait to be called back in again because they were worried about driving overnight. You can imagine if you're, let's say, a nurse that lives 20 minutes away and it's 2 a.m. on a Friday, the safest thing for you probably is not to be going in and out on the roads at nighttime, right? So lots of tough questions with this one. And like I mentioned, if you happen to be signed up for this breakout group, you're going to learn more about this case from Dr. Combs and Dr. Zelanka in their session called Digesting the Ethics, Exploring Responsibility and Autonomy in Patients with RFBI.
Okay, this next case to present to you all is mine to present. This is about decision-making in pediatrics. We kindly received this case from Dr. Drew Lasky, who's at Randall Children's Hospital, and Sarah Porter, LCSW at Legacy Health. They'll be presenting that breakout session that'll be titled Considerations of Parental Authority and Decision-Making in Pediatric Ethics. Next slide. So this is a case about Rose. And, for any of us, when children are injured or sick, that's often really difficult. It's terribly hard to think about the future of a really young person being forever changed. And unfortunately, poor Rose was a 7-year-old, previously healthy child. She presented to the hospital after she fell out of a slow-moving farm tractor. Rose suffered a devastating head injury with need for decompressive craniotomy. There was immediate concern for the survivability of her injury, but as many of us know, you never know with a kiddo. Young brains can sometimes surprise us. So she was provided full and extensive medical care with active efforts to decrease cerebral swelling. 3 days into the hospital stay, Rose has unfortunately not improved. She has no purposeful movements and has all of the bedside clinical signs of death by neurologic criteria. The pediatric intensive care unit team believes it's time to move forward with testing to confirm death by neurologic criteria. But Rose's mother is very firmly against testing and is hoping for a miracle. Next slide. Rose's parents happen to be separated, and she splits time between their homes along with her 5-year-old sibling. Her father is not against moving forward with testing, and he's already gotten to the point where he believes his daughter is, quote, gone, unquote. Her mother is supported by her family and her faith community, and despite extensive meetings and information sharing, Mom remains adamantly against testing to confirm death by neurologic criteria. Okay, take a couple minutes to write down things that came to mind for you in presenting this case about Rose. Okay, I hope that was enough time to start to think through those things. These cases unfortunately do happen and are just incredibly painful for everyone involved. Of course, as we think about any patient, whether it's a child or an adult who may have progressed to death by neurologic criteria, we start to think about healthcare resources. Most of our ICUs around the state are pretty full these days, depending on the week. They've certainly been much fuller during COVID. And are we using healthcare resources appropriately? We have very, very limited pediatric intensive care unit beds in this state. And so is it okay to take up one bed for a kiddo who might no longer be alive? Does it matter? And this I thought was, this came to mind for me is does it matter if there are scarce resources? And so if we're short on PICU beds around the state and there are other kiddos who are critically ill and need them, does that matter? Does that change in how we manage this situation? This is very palliative care-y of me, but how do we respond to the mother's prayers for a miracle with empathy? And that's something that we work on a lot in serious illness communication and palliative care is how do we respond to the hope for a miracle while being kind and empathic and trying to build rapport and relationship with families in one of the toughest times in their lives. Once again, as you know, a common theme for Kayla and myself as we thought through these is: are we helping Rose? Are we helping her parents? Are we hurting her by keeping her on machines when she might have progressed to death by neurologic criteria? Are we hurting her parents by keeping her body alive during this time as well? One thing that comes up a lot for me clinically, being an untrained, but someone who works in ethics quite a bit in my health system is who gets to define non-beneficial care? And that, that's a very loaded question, isn't it? Which parents' decisions do we honor? As the medical team, we like dad's decision a heck of a lot more than mom's decision, right? And so, whose do we go with? Who do we owe the decision-making rights to? Legally, in the state of Oregon, they have equal rights, certainly, unless one of them can't, for some reason, be involved in the decision-making. As a physician who helps ICUs sometimes with that, defining that, death by neurologic criteria, one of the things, and it's less likely for a kiddo probably than it is for an older person, but when we do brain death testing, sometimes things happen. People decompensate clinically while we're doing that. Sometimes they Brady down, things can happen. And so if we decide to go ahead and do that testing without the mom's consent, how do we prepare for that? Is that morally okay? Is that ethically okay? And is that legally okay? Which is important very much for a lot of us at the bedside. So those were my thoughts about that one. Again, another challenging case. And so if you are ready to take that deep dive into this tough pediatric case, you'll join Dr. Drew Lasky and Sarah Porter, whose breakout session is titled "That Considerations of Parental Authority and Decision-Making in Pediatric Ethics."
For our final case, we're going to think a little bit about guardianship and surrogate decision-making. And we were gifted this case from Dr. Katie Drago with OHSU and Matthew Sutton, LCSW, who's joining us from Queens Hawaiian Medical Center. They're going to present their breakout session. I think you probably all picked up on the theme here now. But this one is going to be called Guardianship and the Goldilocks Problem. When is guardianship the right fit? Which is a question in my work I would always love to know the answer to. So this is Mr. Z. He's a 70-year-old male with a past medical history that's significant for alcohol use disorder, bipolar disorder, chronic kidney disease, early stage dementia, and houselessness. He and his wife lived a transient lifestyle that they very much enjoyed, but unfortunately, she's recently passed away. And ever since her passing, he became a high emergency room utilizer. So he often presents the emergency room multiple times a day, And when asked a little bit more about that, he says it's because it's easier for him. He was connected to community-based support by his medical team and eventually was able to get in touch with a nephew. He was previously estranged entirely from his family. His only contact was his wife. And so this is just wonderful news that they were able to get back in touch with the nephew. But unfortunately, Mr. Z would often be found wandering in dangerous situations. And, shelter staff, hospital staff, other folks wanted to prevent this from happening. For example, wandering in the street or in traffic or in places, getting lost. But he became very agitated when people tried to prevent him from, doing so. So his decision-making capacity was questioned at multiple different junctures over 2 years of frequent ED utilization. There was not consistent consensus that he lacked capacity or competency. It sort of depended on a couple of different factors: time of day, was he willing to participate, etc. But overall, it was generally deemed that the patient likely doesn't demonstrate decisional capacity in its quote-unquote fullest sense. So some conversation came up around guardianship, and his nephew said he is not comfortable in acting in the role of guardian. And so after months of speaking with multiple providers who were pushing for a public guardian to obtain guardianship so that Mr. Z could be placed in a locked facility to manage his wandering related to dementia, an attorney that was paid for by a social service agency ultimately said that they cannot pursue guardianship. The attorney said that they could probably compel a judge to rule in favor of guardianship, but it was not a strong case due to the inconsistent assessments and information obtained from community-based support and his nephew. And so eventually the case was dropped, much to the dismay of some hospital providers and to the dismay of the social service agency paying for the attorney. But community-based support perseveres, right? The guardianship case was dropped, but that doesn't mean that all of his supports went away. And so they helped his nephew to become his payee and to become his medical power of attorney. His nephew continued learning his uncle's medical conditions, and in their wonderful reconnection, was able to learn a lot about what his uncle valued regarding his own quality of life. They realized highly restrictive placements or really long hospitalizations were just not consistent with Mr. Z's values. And really group and congregate living situations, although perhaps logistically easier given the number of shelters available, were really not easy for Mr. Z to manage. They did not sit well with him. So he was placed in an independent but supported housing facility where he had case management built in, but it was overall considered independent living, where Mr. Z had his own room and his own bathroom. And incredibly, he began to really flourish. He grew familiar with the area and he stopped wandering and getting lost. So the question is not only what are your initial ethical concerns, but also, do you think guardianship should have been pursued as an option for this patient in the first place? Was guardianship the right fit, or was it more of a perhaps easy solution people were searching for? It's a loaded question, but I'll give you a couple of minutes to write it down. All right. This is a tough one, right? They all are. But what I thought about with this case when hearing about it was, I think that guardianship is, I don't think that it is, I know that it is a very permanent infringement oftentimes on a person's autonomy, on their ability to make choices for themselves. And so the first thing I thought reading this case was, what options may be less restrictive, right? And so I thought about this concept that I learned recently about from Disability Rights Oregon, DRO, here in our state. And they talk about supported decision-making. And so that's a tool that allows people with disabilities to retain their decision-making capacity as much as possible by choosing supporters that help them make choices. A person using supported decision-making selects a trusted advisor, such as a friend or a family member. In this case, it would be Mr. Z's nephew, and they serve as supporters. The supporters agree to help the person living with the disability to understand, consider, and communicate decisions, giving the person with the disability, in this case it would be dementia, the tools to make their own informed decisions. And so I had thought, maybe that would be something that might be indicated in this case, but I know the folks presenting this case in the breakout session after will do a much more thorough deep dive. I also thought about how healthcare teams are often put in a difficult position regarding guardianship. Oftentimes we're looking for a surrogate decision maker or a guardian, and we're trying to help our patients as best we can, right? And I think guardianship can feel like a perfect answer to some of the things we're wrestling with. If we only had a guardian, and how wonderful that his nephew is here, he could be the guardian, right? It feels like a slam dunk. We could, get him into a locked facility and then he'll never wander into traffic again. And so I want to be clear that although maybe I've suggested that guardianship maybe is not the right fit for this patient, we're put in a tough spot, right? Because we're trying to help patients get to a place that's safer than where they are now oftentimes, and guardianship can feel like the answer to that.
I'm going to go get the pizza and go.
So if you're interested in learning more about this case, like I mentioned, Dr. Drago and Matthew Sutton are going to present Guardianship and the Goldilocks Problem, another great title, When is Guardianship the Right Fit? So we've spent a good chunk of time talking about some really complex cases. I know we've given you no answers and you're like, this is a lot to sit with, right? You've heard 4 tough cases, you're feeling heavy. That is kind of like the work that a lot of us here do, right? You hear about all kinds of cases. Maybe you're paged all day long like Dr. Mavity and I are with complex palliative care, clinical ethics cases. And over time, right, the resolution doesn't happen immediately. And oftentimes we actually don't know what the resolution is at all for any of these cases. So we wanted to present it this way, although it can feel hard not to have that like what happened next answer, to kind of put you in the shoes of the roles that so many of us are in. So what I hear thrown around a lot, especially after the COVID-19 pandemic, is like moral distress, right? I know as a former bedside nurse, almost every other email I get is like, are you morally distressed? Maybe it says, come have pizza, right? Or come unpack with us. But you hear also the term compassion fatigue thrown around. Maybe you hear the term emotional distress thrown around. And so we thought we would first take a minute to talk about those 3 terms, because I think they're important. And we're probably all feeling in this virtual room some number of the 3 of those right now. So emotional distress is a state of mental anguish experienced by an extreme level of unpleasant emotions. So perhaps after hearing about these cases, we're feeling emotionally distressed because they're sad. They're just heartbreaking in different ways. And I think some could call sadness an unpleasant emotion, right? And so we're sitting with a little bit of emotional distress. And I'll now contrast that with moral distress. That occurs when you make a moral judgment about a case that you're involved in, but there's some type of constraint making it difficult to act on that judgment. Another way to think about that is, I feel like I know the right thing to do, but I don't feel like I can do it. Right? Those are really tough cases. So perhaps with the case of Rose, we're feeling like, well, gosh, I know the right thing to do is test to see, has she experienced death by neurologic criteria? Has sweet Rose passed away? That's the right thing to do, but we're feeling a little constrained in doing it. Right? I think with any one of these cases, you could identify how the team might feel morally distressed. And this third piece here is compassion fatigue. That's a physical and mental exhaustion, like a whole body state of exhaustion that you might experience if you care for sick patients, for traumatized patients, if you're really dealing with healthcare in general. I don't think any unit in a hospital or in a clinic is immune from this, right? Of just the intensity of the emotion, the complexity, the sadness, the illness laced into all of it, that can certainly cause compassion fatigue. So with tough cases, you can experience just emotional distress, right? You could just be sad. Maybe there's nothing you feel morally distressed about. You're just emotionally going through it. Or maybe you've had a wonderful set of patients, but you drive home and your feet hurt and you feel like you just don't have it in you to care anymore. That might be compassion fatigue. And so when we experience one of these, maybe all three of these, the symptoms can look quite intense. One first might be withdrawal, emotional withdrawal from patients and coworkers or loved ones. I certainly feel like in my role as a bedside nurse or in my role as a clinical ethicist, there are times when I get home to my spouse and my child and I feel a little bit unable to engage emotionally. I feel kind of withdrawn, right? Because I'm just sitting so heavily with all that I've experienced in a day. So an unfortunate consequence of that can be, of course, our own internal struggles and also lack of advocacy for patients. Could even cause bad care experiences for patients and their families if they can tell that we're really disconnected from them. There are very acute manifestations of different symptoms. Oh yes, I see the question in the chat. I can certainly hide this. Sometimes we have painful feelings like anger, guilt, depression, anxiety. I often share the story with new nurses that when driving to the hospital, I would actually carry a little trash bag in my car because I was so anxious about the shift that I would feel like I was going to vomit. Like I felt like driving into work that I was going to throw up. And it was such a physical manifestation of the anxiety that I felt going into work. And that wasn't just because I was new. It was because the work was so emotionally challenging when I was working in pediatric hospice. I love that Dr. Mavi reminded me sometimes that presents as panic attacks. I think that's a huge one for folks. Also could look like not wanting to get up in the morning, or like I mentioned, feeling nauseated, all sorts of things. Another key piece here is burnout. I think most folks in healthcare have considered leaving the profession. Studies say, I think it's like 86% of people think about it once a month. And I would guess that that's a conservative number. I would imagine it's higher than that, or maybe more often than that. And so we think about when moral distress builds up, there's this term moral residue. And I imagine that as layers of paint on a wall, where like, imagine every shift you're painting on the wall. By the end of that, right after a year or 2 years or 30 years of working, it is that you have so many layers of paint, you guys, that you can't even chip the paint off anymore. It just feels like this permanent sort of part of you. And that's that moral residue, the buildup of distress to the point that it feels beyond the point of return. The last piece that I'll highlight here, although I'm sure there's more, fatigue. Certainly we can feel unable to care for others at work and beyond. Maybe we come home and we find ourselves struggling to care for our loved ones or for ourselves. It's not difficult to resent patients and their families, to think to yourself, oh my gosh, here we go again. We have another complex case. I don't want to deal with this, right? I think it's hard to hear me saying this out loud. I even feel that, but I do think it's true. We can stereotype patients. We can feel emotionless. We can feel numb. I mean, it's really, we carry a heavy burden, right? And I think that's important to address. So I do also want to share or just highlight that the cases that Dr. Mavdi and I have discussed today, some of which are, they're more common than others. Some of these are quite rare. Some of these you might see often. They're all very intense ethical dilemmas, but it's important to remember anyone working in healthcare or in a field adjacent to healthcare in really any way, shape, or form is exposed to ethical issues on a near daily basis. I've learned a lot from Drs. Bob McCauley and Catherine Brown Saltzman, who taught me a lot about the way I think about moral distress and compassion fatigue. And Catherine Brown Saltzman has this quote that I'm not going to do justice, but she taught me about the idea that even when you're a charge nurse, making your assignment for the nurses on the unit that day, that's an ethically complex decision, right? Do we have the nurses with the most experience take the most complex patients? If we do, how do the newer nurses learn? But if we have the most complex patients on just the newer nurses, are the patients kind of guinea pigs, so to speak, because the newer nurses are learning on them, right? How about the nurse who just lost a parent that's then being asked to care for someone with the exact same age and profile as the parent they just lost, right? So these everyday things we do at the bedside, they're all ethical issues. We're ethically fraught in some sense all day long. And I don't say that to be demoralizing. I say that to sort of lift up folks who are thinking, gosh, I don't know if I interact with cases that are this complicated. You do on every level. It's all really complex.
I just greatly appreciated how Kayla, brought us back from, these really challenging cases again to just, and I want to say it one more time, we all, you don't have to be a clinical ethicist or a palliative care clinician to run into ethical dilemmas every single day. We all do, and those keep us up at night too. And so, those are the things that in identifying it and in naming it, of course, there's been a lot of attention now to trying to address the moral distress, the compassion fatigue, the emotional distress that each and every one of us who's working in healthcare today encounters at some point in their career. And so, the experts, have offered a lot of options for us. Some of us can benefit from journaling. Writing down some of those feelings can be fairly cathartic without having to voice them necessarily. It's sometimes a safer way to do that. I heard a recent presentation from a psychiatrist who was talking about the importance of when you're feeling those things, getting back in your body. And so really getting a physical connection with yourself, with the earth. And so walking, exercising, touching grass, just really trying to get back into your body and out of your mind and heart that are spinning. Meditating can be really helpful for some of us, using our breath to quiet our minds. Therapy. Boy, it's nice to have a good therapist when you really need to talk through some things. And so that's, many of us have that as something our health systems may offer to us to help us with that, to help try to prevent burnout. Participating with art, either actually just seeing art or making art ourselves in really any kind of modality. Of course, spending time with loved ones, especially if those loved ones happen to not be in the medical field. It's awfully nice to get back out of talking about medicine all the time and getting back into other people's lives. Getting some darn good rest away from work, sleep without a beeper, getting some protected time away from work certainly helps a lot of us. Schwartz rounds, which I know some of our larger health systems are actively participating in, and it's something that I've just newly become aware of as we're looking into this at St. Charles. So for any of you who haven't had much exposure to this so far, it's like a grand rounds or an M&M maybe even, but instead of talking about the medical issues with the case, you talk about the emotional and the soul issues with the case. And that can be incredibly powerful, especially for clinicians who might have been raised in a way in their training where you weren't supposed to share those emotions. And then last but not least, that a lot of us who work in end-of-life care find actually really incredibly helpful is bereavement rounds. Just taking that time to process, taking that time to say goodbye to people whose lives we've touched and who very much touched ours as well. As Kayla and I were working on this presentation together as an ethicist and a palliative care clinician in front of you, we started talking about that overlap and thinking about, what's similar, and what's dissimilar about, palliative care and ethics. And to be honest, in this and these challenging cases, which I could have gotten consulted on any of these cases for sure, as if I was a palliative care consultant on call. I think one of the resonating themes is that we work in these areas where we have constant exposure to incredibly stressful, but I'm also going to label them incredibly sad times in other people's lives. And the risk that we have in caring for folks like this over the lifetime of a career is that if we don't do the work, then the accumulation of emotional baggage is real. It might not be the first tough case of a loss of a young mother or a loss of a child or a loss of, the patriarch of a family and the family's devastated. It might not be those, but as they build up over the years, it truly can lead to an inability to continue to practice in whatever discipline you are caring for patients in. And so I think that's what we're trying to highlight here is that that's our overlap, the need to really take enough care of yourself to not build up the cumulative emotional baggage.
So we wanted to think about what are some of the unusual ways to work through some of this difficulty, right? We talked about maybe something you've heard before, some of the concepts Dr. Mavity presented. Maybe your nurse manager emailed you those and said, you know, take a walk, do some journaling. But we wanted to throw out there, like, what if you screamed into the abyss? I do that in my car, not on a regular basis, right? I'll get in the car and just scream for a moment. And I think there's something really healing to that. Sometimes I try to take, I love the suggestion, a 2-minute dance party. Absolutely. Play some great music. Find unusual ways to cope, right? I love the idea of taking real breaks. I don't know that we're always encouraged to do that in medicine or in adjacent fields, but you know, I hate to say it, but like try to use that PTO, and this is a reminder to me too, really try not to check your email. Try to maybe ignore social media. Maybe that can be not helpful to mental health or just coping in general. Consider setting boundaries. That's one that I always hear that people always say, you know, try to set boundaries. And it's like, all right, well, how do I do that? I highly recommend looking into resources and examples of how to set boundaries in your own work or in a setting that works for you in a way that, not to take away from how you care for patients or your loved ones, but just to ensure that you don't burn out yourself. I really like this idea of re-engaging in compassion. I'll tell you that I did not decide to go into healthcare for like the ease of it or for the high pay, right? I think a lot of us chose to enter into this field because we like caring for people. And oftentimes other tasks take away from our ability to do that. And so sometimes I'll say, you know what, I'm going to chart this tomorrow. I'm going to go pull up a chair, sit with a patient who's suffering. I'm going to hold their hand. We're going to have a nice conversation. Is that the best use of my time? Potentially it's not, but it might be something that I need to feel like I'm reminded of why I do this work. I think it's last couple of things I promise: self-compassion and acknowledging the truth of the work. No one is perfect at this, and it is incredibly difficult. And oftentimes when we work in healthcare or a similar field, our friends also work in those similar fields, right? And I find myself thinking, well, gosh, everyone I know has a tough job. Everyone I know is at the bedside. Like, is it really that tough, or am I just not capable? And am I just weak for feeling this emotion today? So just a reminder, really be compassionate with yourself and remind yourself that this is wildly difficult and a lot of people can't do it or are not up for the task. So I think it's worth being really proud of. Yeah, I love this comment about focusing on gratitude to help reframe. Well said. If you have any other thoughts of kind of unusual ways that we can cope through and process, I'd love to hear them in the chat. I'll quickly read a poem and then just one more slide, and I promise we'll send you on your way. This is I Worried by Mary Oliver. I worried a lot. Will the garden grow? Will the rivers flow in the right direction? Will the earth turn as it was taught? And if not, how shall I correct it? Was I right? Was I wrong? Will I be forgiven? Can I do better? Will I ever be able to sing? Even the sparrows can do it, and I am, well, hopeless. Is my eyesight fading, or am I just imagining it? Am I going to get rheumatism, lockjaw, dementia? Finally, I saw that worrying had come to nothing. So I gave it up, and I took my old body and went out into the morning and sang. Final slide, I promise. Our morning speaker, Dr. Dudzinski, has this incredible book series called Complex Ethics Consultations, Cases That Haunt Us, and that was very inspiring to us as we navigated these slides. So with our 2 minutes left, I'll call out a great comment in the chat. I want to acknowledge that even when we do everything correctly, it can still be challenging. Utilizing self-care strategies doesn't guarantee that our emotions will completely resolve or that our tasks will become effortless. Yeah, I completely agree. I have a question for you, Laura, in the chat. Do you agree with me that the well of compassion is quite variable from one caregiver to another, and the diversity of valid renewal is great?
Oh, wow, that's a challenging one from Dr. Forsyth. The well of compassion, you know, I think everyone's well is just different. And I think that we all have the human existence really gives us incredible abilities of having compassion and of being empathic, and how we tap into it, I think, is truly the individuality of it.
Thank you all so much for joining us and for sitting in these heavy cases with us. I hope you get a chance to take a deep breath, maybe to go outside, dance around in the rain. I like that 2-minute dance party idea. I'm going to write that one down. And just a reminder, at 2:15, you're going to join a breakout group where you're going to get to deep dive into one of the 4 cases that Dr. Mabity and I presented today.
Thanks, everybody.
I'm incredibly excited to welcome Dr. Devin Stahl. Dr. Stahl is an associate professor of religion in the Department of Religion at Baylor University, an adjunct associate professor at the Baylor College of Medicine, where she specializes in disability theology, bioethics, and the visual arts within medicine. She completed her doctorate in philosophy and healthcare ethics from St. Louis University and holds a Master of Divinity from Vanderbilt University. She's also worked and does work as a hospital-based clinical ethicist and has trained as a hospital chaplain. Dr. Stahl has experience teaching bioethics and disability ethics to undergraduate and graduate students in religion as well as medical students. Her latest book, Bioenhancement and the Vulnerable Body, explores bioenhancement technologies from the perspective of minoritized communities. She's been an invited speaker at national and international conferences, is the author of numerous book chapters, and the recipient of various grant awards for her research and scholarship. Dr. Stahl co-hosts Bioethics for the People, an exciting podcast that everyone should check out, which explores the ethical implications of new technologies and scientific discoveries, and it is currently in its 5th season. I'm also lucky to call Devin, should I say Dr. Stahl, a friend and someone who I have deep respect for. One of those people who, when I am wondering what integrity might look like in trying to answer a complex ethical question, she's the kind of person to whom I want to turn. So without any further introductions, Dr. Stahl, thank you for being here, closing us out, and take it away.
Thanks, Tyler. Good afternoon. It's really nice to be with you all today to deliver this final lecture. I appreciate you sticking around until the very end. I can tell there's a lot of people still here, so you must be enjoying the conference. Special thanks to OHSU and Tyler and Kayla for inviting me today. So here we go. Today I'm going to talk about the intersections of bioethics and disability ethics. This is an important topic for me, not only because bioethics and disability ethics are the 2 classes I teach at my current institution, but because they're the 2 topics that I am most passionate about. When I was 22 years old, I was diagnosed with MS. And this diagnosis came after months of medical testing after I lost sensation in my feet and my legs. And it took my neurologist all of 20 seconds to look through my MRIs and declare that I had MS. To say he was indelicate would be an understatement. How can you be sure? I asked. Because I'm a specialist and I know what I'm looking for, he responded. Thus began my entry into the world of healthcare and disability. What I experienced as odd bodily sensations were now symptoms, and I was told to carefully monitor these symptoms for signs of disease progression. You'll be in a wheelchair in 5 years, my doctor said. That was about 20 years ago, and so far, no wheelchair. He was catastrophizing. That's the term that disability scholars give to physicians and other healthcare providers who provide an overestimate of the impact of disability on a patient's future life. Of course, physicians should prognosticate. It's important to know if you have years or months or days to live and what future disabilities you might encounter. But discussions of future disability and quality of life should be careful conversations and not blunt assertions. I've met countless disabled people whose parents were told that they would never walk, talk, or that they would die young. Perhaps even more egregious, I've met many parents who were told by physicians that parenting a disabled child would ruin their marriage and probably their lives. This is not only blunt, but it's just statistically untrue. My most charitable understanding of these statements is that healthcare practitioners are trying to prepare people and their parents for a difficult road ahead. And certainly disability can be difficult. but it's rarely difficult for the reasons that physicians expect. Yes, it's true that sometimes my body hurts, that sometimes I'm so tired I can't think straight. Hopefully that's not at this exact moment, but we'll see in half an hour or so. But the hardest part about being disabled for me and many of my disabled friends isn't my body. It's the stigma and shame that surrounds disability. The uninvited judgments or speculations about the causes of my chronic illness, the patronizing or pitying statements about my bravery, the dehumanizing metaphors and symbols about disability that seem to saturate our language, and the lack of accessible architecture and equipment in hospitals and other places. If I could convince my healthcare providers of just one thing, it would be this: my life is not worse because of my disability. In fact, my life is richer for having experienced disability. It has brought me into relationship with incredible people and has made me a much more empathetic person and fierce advocate for equity and accessibility. Of course, I don't speak for all disabled people. I am, however, part of a community that is desperate to reframe the narrative around disability. So today I want to share some of what I've learned about disability ethics from disability scholars and advocates that I believe are vital lessons for healthcare providers. I also want to point out this art on this slide is my sister's art, which she makes from, she's a print artist and she incorporates my MRIs into her art. So you can see sort of my brain scans in this. It's a sort of, in my mind, a beautiful kind of reimagining of what my body looks like as told through somebody who loves me rather than somebody who's merely sort of scanning my brain to find lesions. So I'm going to structure my talk today around some do's and don'ts that I've gleaned from disability ethics that I believe are applicable to the healthcare field. Also, it seems like whenever I give a talk about disability, somebody just wants to go, but what do I do? So hopefully today I'm going to just tell you what you should do and then some things that you should not do. So we should be careful not to assume that disability lowers quality of life, to conflate disability with suffering, or to practice what I'm going to call a curative imaginary. On the other hand, we should ensure healthcare spaces are accessible, learn about disability rights, culture, and history, and assume that our patients are experts in living with disability. All right, so the first lesson I've already insinuated. There is an implicit assumption in our society that disability always, or at least almost always, makes an individual's life worse. Sure, you may be thinking, some people with disabilities are really good at coping with their hardships and may even become better people because of their disability, but disability is still a bad thing that happens to a person. Nobody wants a disability. That's why we eat right and exercise and fill out advance directives saying we'd rather die than become disabled. Many of us think that this way because we implicitly understand disability through what disability scholars call the medical model. Medicine didn't exactly invent the concept of disability, but we live in a medicalized culture that tends to understand bodily anomalies or impairments as problems that reside in individuals. The problem of disability is a problem of the body or of the mind. The solution to the problem is to fix the body or mind as best we can. In our modern culture, fixing disability falls under the domain of medicine, thus the medical model. I like this illustration from an organization that works with taxi cab drivers. It just kind of illustrates pretty clearly kind of how the medical model is going to frame disability as an individual problem. So most disability scholars prefer that you understand disability differently, not as an individual problem, but as a social one. The social model of disability frames disability as a problem of inaccessibility, stigma, and ableism. What makes life hard for disabled people is a lack of ramps, inflexible work requirements, belittling attitudes, and low expectations. In other words, it's our architecture, institutions, and attitudes that disable people, not their individual bodies. This is not to suggest that in a perfectly constructed world, the chronic pain or fatigue I experience would be inconsequential, but rather that most of the harms of disability did not stem from our bodily or mental configurations, but from our social configurations. So what does all this have to do with quality of life? Well, it suggests that quality of life is not inherently linked to an individual's impairments. Like any minoritized population, people with disabilities find ways to lead good and fulfilling lives despite discrimination. In fact, studies show that people with various disabilities consistently rate their quality of life approximately the same as people without disabilities. But the medical model of disability is so ingrained in our culture, it's hard for many people to believe that people with disabilities can have good lives. Disability scholars refer to this as the disability paradox. Healthcare professionals in particular have an entrenched belief that disability automatically lowers quality of life. Just as an example, one study found that only 17% of providers believed a person with a spinal cord injury would have an average or better quality of life after the injury, compared with 86% of people with a spinal cord injury who said that their quality of life returned to their pre-injury states. More recently, Lisa Iazzoni and colleagues found that 82% of physicians believe people with disabilities have a worse quality of life than non-disabled people. Believing people with disabilities have a low quality of life makes many people fearful of acquiring disability, and then they pity disabled people. These prejudices can then influence how we treat disabled people, befriend disabled people, or work toward or against the full equality of people with disabilities. But when physicians and other healthcare professionals believe the myth that disability is tied to low quality of life, the results can be deadly. As I detail in a recent article, misconceptions about a disabled patient's quality of life can lead to futility declarations, recommendations for comfort care for patients who are not terminally ill, and deprioritizing people with disabilities when we need to ration medical treatments, as some of our hospitals did during the pandemic. Relatedly, we should be careful not to assume that all disabled people suffer from disability. Some disability scholars call this the fragility bias, which is when people perceive people with disabilities as suffering more than non-disabled people. The myth of disabled suffering is also called the quote-unquote ableist conflation, in which disability, suffering, and death get conflated. You've likely seen all these terms lumped together. For example, we must push for biomedical research because if we don't, the result will be increased death, suffering, or disability. Rhetorically, disease, disability, death go together so easily, it's barely worth noticing the differences between them. But what could we possibly mean when we say that disability causes suffering? After all, it's not clear that all disabilities cause physical pain. Deafness, blindness, autism, and a myriad of other disabilities are not in and of themselves painful experiences, yet they seem to invoke the same feelings of pity. When I tell people I have MS, the first thing they often say is, "I'm sorry." And I'm not alone. Studies show that most parents who are informed that their unborn child has a disability or chromosomal anomaly hear first, "I'm sorry to tell you, but," proceed with diagnosis. Studies show that those who acquire disabilities are intimately affected by how they're treated by medical staff. When medical staff are perceived as harboring negative attitudes about disability, patients are more likely to absorb negative attitudes about themselves. Similarly, parents' fear and anxiety were increased if medical staff chose to present what parents later perceived to be overly negative information at the time their children were diagnosed with intellectual disabilities. Even if by suffering we mean something more like existential suffering, it's hard to believe that all people with disabilities suffer. My friends with Down syndrome, my blind friends and deaf friends rarely describe themselves as suffering, or at least not any more so than any other person at any given time. Of course, there are disabilities that are concomitant with experiences of pain and suffering. But insofar as disability encompasses a wide range of heterogeneous bodily and mental variations, it's patently absurd to say all people with disabilities suffer. People with disabilities comprise over 20% of our population. They are the largest minority group in the world, and so generalizations about disabled people should be kept to a minimum. There is no one disability experience, and so we must treat disabled people as individuals and not assume anything about their quality of life or their suffering. Suffering is the projection of non-disabled people onto disabled bodies. It's a bias that can easily affect how we treat people. The danger of healthcare professionals conflating disability, suffering, and death is perhaps obvious. Healthcare practitioners who believe disability causes suffering, and in some cases is worse than death, tend to treat disabled patients more conservatively, meaning they're less likely to pursue aggressive, life-saving treatments. Sometimes physicians will say this explicitly, but I think more than often it's an implicit bias that lurks around covertly, but still sways how physicians make recommendations. I can't tell you how many times I've been asked something along the lines of, sure, you say you don't mind being disabled, but if you could take a pill right now that would cure your MS, wouldn't you take it? My questioner thinks they have the trump card here, because honestly, I might. If I could avoid my annual MRI exams, memory tests, heart monitors, quarterly lab draws, relapse steroid sessions, and the 10 or so daily medications I take, I might take that one pill. But that might say as much about the bureaucracy of our medical system than it does about my feelings about disability. The magic pill question is meant to show that we disabled people would rather be able-bodied if we could, and so being disabled must be bad. Now, I absolutely know disabled people who would not take that magic pill. But no matter how we answer that gotcha question, that doesn't mean that disabled people all secretly and desperately want to be cured, or that they would try any and all treatments meant to fix their disabilities. Of course, there are classic cases of disabled people who pursue medical treatments at any cost, and those people tend to get lots of attention from the media. In fact, we had and still have an entire industry of telethons that parade people across the stage, mostly children, looking pitiable and tragic to help fundraise for a cure or for medical research to ensure that more children like them are never born. We live in a society obsessed with cure. And of course, modern medicine has found cures to many ailments that we ought to be grateful for. I would much rather have MS today than in any previous time. But what comes with that drive for a cure is what some disability scholars call the curative imaginary. It's hard not to see disability and assume it would be better to cure it. Why else would we put untold amounts of money into identifying autism genes, enhanced prenatal screenings, and exoskeletons to help paralyzed people walk again? Not all of this research is supported by the disabled populations that are supposedly the target of the medical cure being investigated. Some of this research is meant to eliminate disabled people, while other technologies like the exoskeleton were designed with little input from paralyzed people, most of whom say they would rather have accessible sidewalks and functioning wheelchairs than giant metal contraptions hoisted onto their bodies. You'd hardly know that, however, because if you Google something like, "Do paralyzed people want exoskeletons?" you'll find dozens of news stories touting the amazing potential of exoskeletons to help people walk. Just look at this ad campaign. In this image, in which a normative-looking white man is captured in 7 panes, moving from a wheelchair to walking, it's clearly an analogy for the march of progress. The message is obvious. Standing is progress from sitting, and everyone would rather stand. Of course, lots of people with disabilities seek out medical care, but we shouldn't assume that what disabled people primarily want is a cure for their disability, or that they would do anything to get a cure. A ridiculous number of assisted devices are designed without consulting their disabled end user, and funding often goes to high-tech new devices rather than community access projects. The message is clear. Disabled bodies are the problem, not inaccessible environments. Rather than assume It's important to check in with patients to see what their goals of care are and what, if anything, makes their lives difficult. All right, so let's shift to the positive. What should we do then? Along these lines, it's important that we attune ourselves to the inaccessibility that surrounds us. 50 years after Section 504 and 34 years after the passage of the ADA, a staggering amount of hospitals and clinics still don't have basic accessible equipment and facilities. People with disabilities experience barriers to timely, high-quality care due to a lack of accessible medical facilities and examination equipment. This is both humiliating and deadly. 60% of doctors do not use accessible exam tables and chairs. Patients who use wheelchairs are routinely examined in their wheelchairs because clinics don't have accessible exam tables or transfer assistance to get patients onto tables. A medical exam performed in a wheelchair can ignore developing pressure sores and other ailments. Other disabled people have difficulty even finding providers who will accept them as patients. A recent study by Iazoni revealed that a substantial minority of physicians actively try to not accept or stop seeing patients with disabilities. And a whopping 68% of physicians worry they're at risk for an ADA lawsuit because they know little to nothing about their legal responsibilities under the ADA. Among women with physical disabilities, a third report being denied services at a doctor's office solely because of their disabilities. And 56% of women with disabilities who have given birth in hospitals reported that the hospital failed to prepare for needed disability-specific accommodations. Disabled women are far less likely to receive pap smears and mammograms, which is perhaps why they're much more likely to die of breast and cervical cancer. Thankfully, the U.S. Department of Justice is proposing a rule under the ADA that would adopt technical standards spelling out responsibilities of hospitals and healthcare clinics operated by state or local governments under the law. But this comes only after many complaints by disabled people that their doctors couldn't get their weight because they didn't have accessible scales, receiving annual exams from the waist up only, people who were scared to go to the doctor after being placed on beds without rails, people who were helped onto exam tables and then sat there for over an hour waiting for someone to help them back into their wheelchair so they could go home. The complaints and the lawsuits are manifold. Of course, this rule will only apply to public hospitals and health clinics. We have a long way to go to end the significant health disparities that people with disabilities face. We can all do our part by understanding what our patients need and what the ADA requires. But knowing and treating our disabled patients well is about more than accessibility. That to me is the bare minimum. Healthcare providers should learn about disability culture, disability rights, and disability history. I often meet healthcare providers who are taken aback when their patients are suspicious of them or reject their care because they don't understand the history of how medicine has treated disabled people. From the eugenics movement to institutionalization to lobotomy, the American medical establishment has championed many pursuits aimed at eliminating or alienating people with disabilities from our society. I can't blame healthcare providers for not knowing this history. 81% of medical students report not receiving any clinical instruction on disability, and only 2% of practicing physicians report having a disability themselves. Part of the reason for this is that the technical standards required for medical school exclude a lot of disabled people. So most physicians with disabilities acquire them after medical school. And disabled physicians experience considerable discrimination from other physicians. So this graphic here accompanied an article in which a doctor who uses a wheelchair discusses a time in which he was rounding and a staff member at the hospital called him out as a patient instead of a physician. Medical schools teach students about diseases so rare that they affect 1 in a million people. Yet there's only been halting progress in the care of tens of millions of Americans with disabilities. Thankfully, there are a number of books and articles helping people to understand disability culture and history, as well as initiatives to help healthcare providers learn about disability. So like this book from the reporter Joseph Shapiro, or this new set of instructions from the Hastings Center. But if you're not much of a reader, just hop onto social media. As one doctor puts it, I have learned more about disability rights, culture, and disparities affecting the disabled community from teenagers and Twitter than I ever did in medical school. So follow activists like Alice Wong, organizations like Autistic Self-Advocacy Network, or the hashtag, don't be offended, it's the hashtag doctors are dickheads, to see stories about how ableism in medicine affects disabled people. If you aren't one for reading or social media, I have more good news. Unless an individual is going in for a disability-specific specialty care, it is helpful but not necessary for a healthcare professional to have clinical knowledge of the patient's specific disability. If someone's going in for a generic healthcare visit, like a checkup, it's usually enough for a professional to ask questions, take time with their patient, learn from feedback, and adjust their approach. In other words, a professional's competency in treating disabled people is first and foremost an extension of a patient-centered approach in general. And of course, having a good relationship with your patient matters. A practitioner's bedside manner can greatly impact patients' health, aiding their efforts to lose weight, lower their blood pressure, or manage painful symptoms. In fact, researchers have found that the impact of establishing a good relationship was greater than the reported effects of low-dose aspirin or cholesterol-lowering statins for preventing a heart attack. So good bedside manner is good medicine. And finally, assume, until proven otherwise, that your patient can make their own medical decisions, and they can teach you about what it's like to live with disability. My healthcare providers know way more about reading my MRIs, lab results, and the risks of medications than I do. But I know what it's like to live in my body. I know when I'm relapsing. I know what to expect before, during, and after a relapse. I know when something feels off. As a middle-aged white professor of bioethics, I'm more often than not given the benefit of the doubt that I know what I'm talking about. But many disabled people aren't. People with both intellectual and physical disabilities are often assumed to be incapable of understanding or making medical choices. Patients with intellectual disabilities are often automatically assumed as incompetent or incapacitated to make their own medical decisions or to fill out advance directives. Few healthcare professionals I encounter have ever heard of the concept of supported decision-making, in which a person with an intellectual disability appoints a trusted person to bounce ideas off of. Patients and care providers are coerced into guardianships, even though guardianship can strip people of some of their most basic rights. I just heard a really great presentation on guardianship. It can go much better than this, but it can also really reduce the ability of people to make their own decisions. Even people with physical disabilities experience a plague of low expectations. Far too many healthcare providers speak first to a person pushing the wheelchair than its user, and physicians commonly believe that their deaf patients have a low IQ. Assume your disabled patients can teach you about their disability. Perhaps one of the most important things we can all do is to elevate our disabled patients as experts on living with disability. As disability scholars frequently point out, it's actually really hard to imagine what it's like to live with a disability. You can't blindfold yourself and know what it's like to be blind, or wear noise-canceling headphones and know what it's like to be deaf. There's actually been research on this. There was a time when well-intentioned researchers thought that play acting at disability would provide insight into the disability experience. They'd have people navigate spaces in a wheelchair or blindfold them. There are at least two obvious problems with these activities. First, it assumes that the experience of blindness or deafness is a mere lack of sight or sound. but people who are blind and deaf will readily point out that their disabilities are not mere lacks, they're also gains. Deaf gain is the term used to describe the rich experience of deaf people living in deaf communities that are designed for them and where they can communicate freely and easily with one another. Second, play acting a disability is necessarily short-term. Those who are born with disabilities do not know some other sort of life in which they don't have their disability, and those who acquire disabilities can take considerable time to adjust to their new embodiment. That can't be done in a day. It turns out that play acting a disability leaves actors with two impressions. Disability is awful, and people with disability should be pitied. This is exactly the opposite of what disability advocates want us to learn. So instead of imagining or play acting, we need to actually talk to people with disabilities and read their stories. Thankfully, there are way more resources than there used to be. Read the wonderful New York Times column, Stories About Us, or listen to Alice Wong's podcast, Disability Visibility. Hearing and reading first-person narratives give us new insight into people's experiences. So of course, there's way more to say about disability ethics and bioethics than I can say in a kind of short period of time like this. And I actually have tons of time for question and answer, because I'd love to get some of your experiences and some of your reactions to this. But I hope this is all a starting point for rethinking the way that we talk about and treat people with disabilities. So thanks for indulging me here, and I would love to open up a conversation with everyone.
Thanks, Devin. All right, everyone, this is great. We have plenty of time for conversation. While you marshal your questions, feel free to put them into the chat, and I will curate them. Devin, as I'm listening to your talk, I'm wondering, when you are encountering this sort of, I guess let me rephrase my question. Do you think about the context of, let's say in the last 10 years, 5 to 10 years, there's been a lot more of sort of recognition and push to get rid of the kind of isms that kind of plague American culture, racism, sexism, et cetera. And in medicine, we've had this massive push to, for instance, become anti-racist establishments. OHSU, where I work, that's over the last 5 years has probably been the #1 goal. Anti-ableism has not seen that same kind of traction, I think, in medical discourses. And you've given us some reasons why I think we could understand that to be the case, but I just wondered if you feel like, I guess, one, diagnostically, why that might be the case, and two, what we can learn from the success of other movements, either generally or particularly within the healthcare establishment.
Yeah, when I ask medical trainees and other healthcare providers about this, I think part of it's the way that we teach about or don't teach about disability, but disability seems to fall into the realm of like other things that healthcare professionals are trained to cure and trained to sort of try to prevent. And so it's really hard to think when your training is to identify quote unquote problems or anomalies or abnormalities, and you see disability as falling into those categories, right? You're not trained to see Blackness or femaleness as like an inherent problem, but you're often trained to see disability as an inherent problem. And so reframing disability around a social model or around the idea that there's some kind of social constructedness to disability, most of the time when I say that, people have never heard of that, right? So to imagine the disability community as another minoritized community is pretty new for people. I think people inside healthcare and outside healthcare. But disability advocates have been pushing that kind of framing for many, many decades. So I'm not sure always why we're not getting as much traction with that. But I do think that that kind of framing hopefully opens up a different sort of conversation. There are certainly people with disabilities who want access to healthcare and even sometimes want cures and things like this, but there's a kind of assumption that that's always true for this population, and that's a faulty assumption.
Thank you. We have a question. In my experience, healthcare professionals often assume patients with a developmental disability lack decisional capacity. I often advocate for supported decision-making. Is there a better way to think through this?
No, that's what I want to advocate for too. And I gave a presentation just at Providence a couple of days ago about this, about why we shouldn't jump straight into overriding people's decisions, but we want to enhance people's autonomy. And so I think one way to frame this is a supported decision person acts as a kind of ADA accommodation, just like any other kind of accommodation would. So they can be a kind of cognitive prosthesis. So another person can step into a role and help to both translate and make sense of what the medical team is saying to the patient. This actually probably is super important for all sorts of people, not just folks with intellectual disabilities, because as you all know, sometimes it's really hard to understand what your physician's saying to you at any given time. So, but having a support person act as a kind of accommodation is really important. And in Oregon, you now have a law demanding that you allow such people into the hospital. So your Senate bill says that you have to allow people to have 3 people and 1 always in the hospital with them. So thinking about this not as wouldn't it be nice if this person had a support person, but actually we're legally mandated to allow a support person into the hospital is, at least in my experience, sometimes when you throw down the law gauntlet, people listen to you a little bit better. It's not just a nice thing to do, it's actually required of us, and we should be meeting the bare minimum standard here.
That's a great answer. Thank you. So we have a question. In pediatrics, any suggestion on how to approach quality of life prognostication from a factual perspective, from a non-ableism approach? And I would even say you could extend that to prenatal conversations around what the future will be like.
Mm-hmm. Yeah, what I've heard from folks who work a lot in this area is that, so on the front end, it's important to try to not use value-laden language or negative or positive language in a diagnosis. So as I think a lot of people are trained to say things like, I'm sorry, but, and they use a kind of bad news protocol in their communication. But a lot of people will say that sort of sets people up to think about their children as a negative and end up resenting that. So for people who continue on with pregnancy, they come to resent that sort of diagnostic moment. So remembering to deliver that news in as neutral a way as possible, and then allowing folks who say they want it access to people whose children have the same diagnosis. So it's really hard to imagine what it's like to parent a child with a disability if you've never known another parent who is parenting a child with a disability like that, right? How could you imagine it? And so if your only imagination is really sort of catastrophic, it's going to feel really catastrophic. I've done some work around just even how children are pictured in medical textbooks around disability, and some of the old school ones with the black bars across their eyes and they're naked and there's all this diagnostic stuff happening in the textbook really sets you up for a pretty dehumanizing vision of that person. So instead, talking with other families, and I don't think that other families are going to provide some ultra romanticized view of what it's like. It can be difficult, but you need to know it can be difficult, and it can be, a lot of parents will say it's amazing for their families. And so you need to be able to hear kind of realistically what it's going to be like. And the only way to do that is to talk to people who've lived that. So at least offering that as a something that you can provide. I think that the hospital could provide if people want it. I wouldn't force that on anyone, but if they wanted to talk to other parents, that it'd be easy to find other parents who can provide that kind of information.
I agree. We have some good commentary around the extent to which, after hearing your talk, folks no longer doubt, if they ever doubted it, that there was this sort of stigma of kind of wanting to cull out people who have disabilities from the medical community. I have a question. How do you find the general lack of distinction between a physical, intellectual, or other kinds of disabilities in the disability studies and disability ethics movement? And do you think that that's a problem, or do you think they should be totally separated? Kind of how do you address that, kind of maybe theoretically and or practically?
Yeah, yeah. So there's a couple different ways to think about this. First of all, one thing to say is like, what a heterogeneous group of people, right? So we're talking about like, what is bipolar disorder and MS and schizophrenia and autism and paralysis? Like, what do all those things have in common? In some ways, nothing, right? Like those embodied mind-body experiences are really, really different. And so in some ways, it's like kind of odd to talk about all the folks with those characteristics as all being part of one group. And there's like a long history, which I encourage you to read more about why we have this modern concept of disability. But one reason I don't want to let go of it is because it's the history of the disability rights movement started as a history of individual groups advocating for the folks in their group that had their same characteristic. And it was just very piecemeal. When you get people together in alignment to advocate for their group, it just has a kind of political force that is more powerful than if we did this individually. So part of the reason to continue to talk about a disabled community is that there's like natural alliances. We are fighting often for the same sorts of things. And we can do that better together than separate. That doesn't mean we sort of ignore the fact that lots of our particular challenges are particular. But I wouldn't want to wholly separate out, once again, as we used to do like at the early 20th century, groups into individual groups who advocate for different things. Because what I think unites disability, and this is kind of the reason that disability scholars want to use disability models rather than disability definitions, is that models help to kind of frame what it is that all of folks who are called disabled share in common. And what they don't share is particular kinds of embodiment, but a lack of accessibility in the environments that we have. And so there's a kind of political force in keeping folks together and advocating for one another. And I think a lot of disability scholarship right now is trying to overcome some of the hierarchies that have embedded themselves even within the movement. Just like any other minority group, it tends to get hierarchical, right? Where some people are kind of at the top of the disability hierarchy, where others are at the bottom. But there's a lot of work happening right now to make that not the case. And I think that there's a lot of like third wave disability advocacy that is really pushing us to consider like the intersectionalities of disability in a really positive way.
Thanks. That's super helpful. Yeah, I think that's the danger is there, and I know most disability scholars recognize that danger of sort of it becoming so diluted that it loses something. But I agree with you. I think it's a really powerful way to think about it in the model versus definition. Kind of to carry on with that point, we have a question. What's a good starting point to help healthcare organizations, maybe speaking there specifically, to provide equitable care to people with disability? Either you could mention either broad strokes or even one or two very concrete things you've heard from your community.
Yeah, I mean, I think some of the just recognizing implicit biases, they're really strong. I mean, the data is really, really clear to me. Although we've had this kind of data for decades and it's like not breaking through, I just, on some level, just want to be like, what do we do? Like, if the folks who are really concerned about data don't seem to care about data, like, what do I do? And so it's a constant, like, sort of trying to figure it out. And some of it, I think, is affective. Some of it's about changing the sort of orientation toward disability. I want folks to recognize that when they see their disabled patients, when they're hospitalized, they're seeing people at their worst, right? We recognize this for all populations, but if you only ever see disabled folks when they're hospitalized, they're not at their best. You're not seeing them at their best because no one is at their best when they're hospitalized. And so I think it kind of entrenches a view of like, gosh, it's so hard to be disabled. It's so bad. I think people just need to start accessing these resources on disability outside of their clinical encounters. So reading the stories, listening to the podcasts, following the hashtags, whatever it is that you do when you consume media, like start allowing other kinds of voices to come into the fore, because those are not the voices you're hearing in the clinical spaces. That's one way. I just think there needs to be this reorientation. If others have ideas on how to do that, I'm all into like the art, right? I'm like, maybe we just need like better art about disability. Like what is going to change people's hearts and minds? It's not data. It's got to be something else, which is why I've gotten so much into the art projects and the first person narratives and like the things that I think actually change people's minds, I think are stories. So how do we promote that in these spaces? I guess I just need to keep pointing people toward them. That's what I've been doing.
Yeah, we have some other good questions. We have time. Okay, I'm going to ask a question, then I'll jump to the other questions. So I'd love to hear your thoughts on these two ideas that I've been sort of mulling over. One is, this is more of an ethical question, but the sense of like what our naive ethical position in reference to the world and where we think of how we think about moral value. Do you think that part of the reason that the ism of ableism has a harder time gaining traction is because there's a deeper bias that it must uproot, perhaps against intellectual disability? I think that I've oftentimes wondered that, at the end of the day, especially if you have intellectual disability, you yourself have a harder time advocating for yourself. So there's a kind of, the number of people who can do it sort of are less in some sense. And also, I think that in our, Western life and in medicine, the bias toward people, seeing people positively who can think and talk and really, perform in those, with those metrics is really powerful. And that's something that I think ableism has to combat that others don't. So I guess that's one. These are unrelated, but you can just riff on either of them. And the other is just money and profit. I think that anti-ableism has to battle against profit in a way that some of the others do not, in that to be an anti-ableist institution, healthcare, you have to invest a lot more than perhaps other eradicating or overturning other discriminatory sets of practices contain. So I don't know if you have just thoughts on either of those.
Yeah, many thoughts on both of those. Yeah, why the ableism? Well, and I think like in the healthcare world, we are like high performing, high achieving, like we did good in school. We were good students. We value our minds quite a bit, right? So when you value a certain capacity in yourself, or you even like sort of see it as the way you identify, it's really then something like intellectual disability or, any cognitive impairment is going to be really threatening to your identity. And it also could happen to you. Like this is one of the minorities that you could wake up tomorrow and be a part of, which is not true of all the other minoritized communities. So there is a kind of fear, I think, that can crop up. If I value some sort of physical capacity that I have, if I value my intellectual capacity quite a bit, the fear of losing that is pretty high. And so there is a kind of revulsion from that, that I think is part of our landscape as well. We really value certain parts of ourselves, and if we were to lose them, it would be terrible. And therefore we can't imagine, right, our lives without those capacities. And yet what we learn from people's stories and from the data is that people are incredibly good at learning to live in the bodies that they have. So we fear it quite a bit. We will all one day, if we are lucky, become disabled. right? People who don't become disabled are just people who were unlucky enough to die young. We will all experience disability at some point in our lives. And for some people, that's really scary. And so you have to sort of overcome that kind of fear in doing any of this work. And you're right that accommodating disabilities often just is more expensive than other kinds of embodiments. So there is that tug. Of course, the ADA does not require you to go bankrupt. In fact, a reasonable accommodation is a thing that won't bankrupt you. If it did, it wouldn't be reasonable anymore. So it is definitely more expensive. And for me, it's so, 25% of our population has a disability and we just don't value them and we don't want to accommodate you, then yeah, don't invest the money, right? If you don't value disabled people, just don't invest in them. If you do, you have to decide, how it is we spend our money. I think as a culture, we do not think about enough about how what we spend money on just reflects our values. This is true on an individual level and on an institutional level. I can tell what your institution values by how it spends its money. I can tell what your family values by how it spends its money. And that, is sort of I'm sure it puts some people on their heels, but it's true. So we invest in what we care about. And if we don't care about people with disabilities, then we're not going to invest in them. So I guess show me how you spend where your budget goes and I'll tell you if you care or not. But it is a reality that I think we just have to contend with. Oh, I can't hear you.
Sorry, I'm muted. I'm going to read a bit here. So great talk and topic. The man's ascent imagery and the message that standing better than sitting, which fits into the medical model of disability, is a powerful example of the kind of hidden narratives described by Dr. Marchenko in her earlier talk and plenary today, the stories we tell. A great symbiosis between y'all's talk. What do you see as important keys to shifting the culture of medical education? And we've talked about this, but let's say specifically toward the social model of disability when those narratives run so deeply at present.
Mm-hmm. Yeah, so the Hastings Center document that I pointed to is a really great place to start. And it outlines just all the kinds of goals you should be trying to meet in medical school. What I have tried to do with medical schools is a number of things. So some of it's just teaching some of that history, right? It's wild to me how many people know about the civil rights movement, know about kind of first wave feminism, but have never heard of the disability rights movement. So I think just teaching some of that history, what is the Capitol crawl and why were people doing this? If you don't know, you don't know. So some of it's about teaching just about that particular history and how it intersects with healthcare. Some of it's getting patients into in front of our students. So getting disabled people in front of our students, telling their stories, doing patient panels with people who are advocates for themselves, who've had lots of interactions with healthcare professionals and what we can learn from them. And then it's almost no medical students learn how to do a physical exam on someone in a wheelchair, just really, really basic stuff. If you don't know how to do it, no wonder we think we can do a physical exam with somebody sitting down in a wheelchair. That is, if no one teaches you how to do it, then you feel uncomfortable and you don't want to do it. So that study from Iazoni showed that doctors told her, this was focus groups of doctors saying, when I have disabled patients, I try to get them out of my practice because I don't know how to care for them. I don't feel like I'm a good provider for them and they're too expensive and I try to force them out. Those were people, there's a social desirability bias in any kind of survey work. And so this is them bluntly saying what they think, also trying to seem like this is a socially desirable response. So that is just wild to me. So people are honestly admitting this. So it's about teaching about some of this history, teaching about these models, getting disabled folks in front of students. That all just can be done. And it's not a niche thing in med school. You're definitely going to have these patients. How are we not teaching you how to take care of them and about what they might value? I don't know. I'm so how could this not be the case that it's hard for me to imagine what the motivations of not doing this are. But deans of medical schools, over half of them say they are not educating enough on disability. So if they know that's true, and 81% of medical students say they never get anything on disability, why aren't we moving faster on this? It's just, I guess, just people don't care. And my goal is to try to make people care.
Powerful. Thank you. Is that your sister's website that you just put in?
Somebody
Art.
asked for more of Darian's art. So she is DarianGoldenstall.com.
Awesome.
All of her art's about illness narrative.
I hope we see a spike in her sales after this. Our money going to a good cause. Do you, I think I know what this question is asking, but I'm going to read it from Celeste. Thank you for the awesome presentation. Could you offer an anti-ableist lens by which to talk about risks, so quote unquote risks associated with interventions that may result in a change to a person's physical experience such that they may be newly disabled? For example, protection of the spine after an injury to protect the spinal cord from further injury that may result in para or quadriplegia. This is often presented as a worst case scenario or paired with the risk of death.
Oh, yikes. I'd love, Celeste, if you said more about this. I'll let you take a second to unmute, but I mean, what again, the data shows us, if we care about data, is that people with spinal cord injury do have a dip. Like, it is very difficult to become paralyzed, but they almost always come back up from the dip in their quality of life to stabilize to where they were pre-injury. So presenting this as like equivalent to death really dishonors the experience of most people with paralysis. But Celeste, do you want to say more?
Can you hear me okay? Oh, good. There was a case where the patient refused to wear a cervical collar and did not want to participate in that care plan. And the risks were presented as risk to quadriplegia and death. They were paired that way. And I think that it led me to want to know more and to be more skilled in talking about risks and risks in general, right? That may result in disability or some sort of physical change that in the medical model is assumed to always be bad. And that may be received as bad from the patient. So not to undermine their perspective either. Is that helpful?
Yeah, thanks. Oh, yeah, there, thanks. One way we talk about this in disability studies is, because this is tricky, right? Because you don't want to say, don't do anything to prevent disability. Disability is great. Everyone should be disabled. This is definitely not what I'm saying. Instead, we talk about transition cost. So even if most people with disabilities learn to find a new equilibrium and have a high quality of life, that does not mean that it's easy to become disabled. There's a huge transition cost. Going from one kind of embodiment to a drastically different kind of embodiment, one that is heavily stigmatized and not well accommodated, is going to be difficult, right? And I don't want anyone to experience that if it could have been prevented, because that is tough on a person's life. So I still want to present, like in your scenario, this is a risk that we would rather that outcome not happen, because we know how hard it is for so many people to transition into a life of disability. That doesn't mean having a disability is terrible or that we should denigrate people's lives because they have a disability, but we do know that that transition is a difficult one, and if we can prevent it, that might be easier on that person overall. So I think that language of transition cost for me spares us from having to say things like, oh, it's so terrible, this would be like death, but at the same time, trying to prevent disabilities when we can, because we know that that transition into disability can be so difficult.
Thank you. I'm going to do one last question. Susan Toll's question here, and I want to, Susan, would you mind just unmuting and asking it? Because I'm not sure if what you mean is there the difference between becoming disabled when you're young and old, or the different kinds of disabilities that you can acquire later in life?
I'm saying congenitally acquired versus much later in life, particularly cognitive impairments. Are there differences that we should be aware of and thinking about as we teach, as we learn, as we enact the wonderful messages you've shared today?
Thank you.
Yeah, thanks. That's a good question. So maybe I'll piggyback on what I was just saying is that so people who are born with disabilities have an entire life to live with that disability and are often, as we see in the data, very good at figuring out how to do that in a way that is fulfilling and they have a high quality of life. And in fact, when you know nothing else, like what else is there to compare it to? So you don't have that kind of transition cost because there's nothing to compare your life to. Whereas if you acquire a disability much later in life, that transition cost might not see itself back in the dip of what can be a very difficult experience. So it might be that if you experience, sort of a quick onset dementia at the end of your life, you don't have the time to learn to like live with that before you die. And so we wouldn't want to sort of just keep telling people, don't worry, you'll learn to live with this. It's going to be fine if they don't have the time to learn how to do that. And so I think in that sense, we might have might be talking about a different thing. I do sometimes worry that, this sort of move toward, and I don't want to open up a whole can of worms now that we're already done, but I'll do it anyway, that these like advanced directives where people are trying to ask for VSED if they can't read a newspaper, right? So don't feed me anymore if I can't read a newspaper, because that wouldn't be a life worth living. I worry that many dementia patients, once they do actually experience dementia, don't find their lives so terrible they'd want to die. And so I worry about sort of making a different sort of standard where we say, sure, if it's dementia at the end of life, then it's fine that we just let people die. Whereas we wouldn't let the child die for that same reason with another kind of cognitive impairment. So transition costs can be sort of different toward the end of life, but I do still worry that we might cut lives short if we don't recognize that some people live into those disabilities quite well, even at the end of life.
Thank you, Devin. Let's give a round of applause for Dr. Stahl's fantastic talk and incredibly engaging 30 minutes of Q&A.
Thanks, everyone.
That Kayla and I are going to chat over. And then we have some announcements for what's on the horizon, so no one go anywhere.
We sure do. That was just incredible. Thank you so much, Devin. And I promise Tyler and I will be short so you can get back to life outside of a computer screen. But I just wanted to say I'm so incredibly grateful to each one of our plenary and breakout speakers. You might have noticed that many of our plenary sessions included folks from outside of our little slice of the country. You also might have noticed that many of our breakout sessions included two speakers from different parts of the state of Oregon. And I think that's one of the wonderful things about a virtual conference. It may have its downsides, but we really got to gather a wonderful group here today. Today shaped the way that I think about advocacy through hospital policy. It inspired me to further examine how social determinants of health are shaped by narratives. I got the chance to chat with you all about navigating compassion fatigue and some tough cases. And now I find myself wondering how to integrate a disability ethics lens into my everyday work here at the Ethics Center at Providence. It's been such a joy to get to spend an entire conference day focused on ethics in our little corner of the country. And I so appreciate all of you. Tyler, before I share more information about Kinsman 2025, what are you thinking about after today's sessions?
Kayla and I are going to take our little show on the road, so I hope everyone's ready for that. I have so many thoughts. I think one thing I'm just really grateful for is for the Kinsman Conference, which, last year we had these sort of like clarion call for a kind of love and social justice to be more present in our bioethics and healthcare organizations in this state. And I've heard those themes repeated over and over the last 12 months. And I cannot wait to hear and reflect on how these conversations we've had today, what the ramifications and the sort of webs of conversations that roll out from this conference will be. I also just really appreciated, and I hope everyone who's been listening today realizes how Kayla and I were kind of remarking how close to the bone all of our speakers remained. You know, it's so easy when you're asked tough questions after a talk to sort of let it float up into kind of gestures or more kind of theoretical reflections. But today it just felt like time and time again we didn't turn away from the hard questions, but really tried to grapple with it together. Another thing that I've been thinking about today is when kind of riffing on our theme of everyday ethics, to be ethical in every day and in an everyday context requires not just an organizational ethic like Dr. Dudzinski talked about, but also not just an individual ethic, but it requires sort of a symbiosis between the two. It's both our responsibilities as individuals in this state and region, and also the responsibilities of our institutions. And there's obviously a sort of osmosis between those two. So I hope that kind of way of thinking about what everyday ethics is and can be continues to carry forward as well. I think those are my primary reflections for the day. So yeah, again, just it's been wonderful. I'll kick it back to you.
I love it. I agree. I feel challenged like on a personal individual level, but I'm also thinking about how do we change our institutions, our policies, our structures? How do we change the whole system, right? It's wonderful. Tyler, do you want a drum roll for me while I announce Kinsman 2025 here? We have wonderful news. I'm really excited to share with you all that next year, Kinsman Annual Bioethics Conference 2025 will be in person again, this time at River House on the Deschutes. It's a hotel and conference center in Bend, Oregon. It will be co-chaired by the brilliant Susan Headland of OHSU and the incredible Dr. Lori Morrison of Kaiser Permanente. I'm really looking forward to reuniting in person together next year. I think it's going to be a lot of fun. And we'll be gathering on April 17th and 18th of 2025. So if you want to take a moment to mark that in your calendars, maybe look at some hotel reservations and start to get excited.
And with that clarification, we will conclude our day. Please join us for our in-person return to in-person next year in Bend, Oregon. And I'm just so grateful for everyone being here and for the incredible preparation from all our speakers. What a wonderful day.
Thank you all so much for joining us.